3D 4 number 4. Is Alex from Elsevier is here with us? If you are there, please write a message in the chat box.
Hello. Hi. Good afternoon. I'm Smriti from Elsevier. I think Alex is there. He has been sharing his screen, but probably not able to share his audio.
No, he's not sharing his screen. I have shared my screen actually. I would like Alex to just write a message so that we can unmute him by just recognizing through which ID he has joined. Or he can raise his hand, give a reaction on the screen. नहीं हुआ ना कुछ Welcome, Ross. I can see you. You have joined. Dr. Atul Gaur has also joined. So now we are going to begin this session. Good afternoon, everyone. We have come to the last session of our CME. A warm welcome to respected speakers, distinguished chairpersons for the session, and dear delegates. You all know that designing of any curriculum or training program that depends up the designing of curriculum of any training program that depends upon the level of the trainees, and it definitely needs customization. The speaker for our this session is going to throw light upon a very unique training that he is running at Scotland, that is the surgical anatomy program for core surgical trainees. So I welcome you, Dr. Ross, for this session. And the chairpersons for this session are Dr. P.K. Sharma and Dr. Anita Tuli. So Dr. Anita Tuli, Dr. Anita Tuli is consultant in Department of Anatomy at Maulana Azad Medical College, New Delhi. She was formerly a director professor and head of anatomy at Lady Hardinge Medical College, New Delhi. She has led the setup of fetal repository, bone bank, and hormone assay lab at the Lady Hardinge Medical College, New Delhi. She was also associated with organ and body donation campaigns. She has organized many cadaveric workshops with other surgical and clinical departments. She has several international and national publications to her credit and has supervised various research projects as chief investigator and co-investigator. I welcome you, ma'am. The second chairperson for this session is Dr. P.K. Sharma. Dr. P.K. Sharma is currently heading the Department of Anatomy at Era Medical College and Hospital at Lucknow. Sir was formerly head of Department of Anatomy at King George's Medical University, and here he established an ultrasound unit for academic and clinical ultrasonography in the Department of Anatomy, KGMU. He also established the CT and MRI scan gallery in the Department of Anatomy, which is of its own kind, first in country. And he has got numerous publications, and he has written a book on imaging anatomy too. His exemplary academic contribution, he has got several exemplary academic contributions in India as well as in US, Australia, UK, China, Mauritius, and Nepal. We welcome you, sir. The guest speaker for today's function, as I have told you, he is Dr. Ross Alexander Jones. Dr. Ross Alexander Jones is lecturer in clinical and surgical anatomy at University of Edinburgh. He did his Bachelor of Science in Medical Science from University of St. Andrews in 2002. Then he did his MB-CHB course from University of Manchester in 2005. He became a member of Royal College of Surgeons of England and Edinburgh in 2008. He was trained in general surgery in Manchester, Dennery from 2007 to 2017. He did his MSc in Human Anatomy from University of Edinburgh in 2012 and PhD in Human Anatomy from the same university in year 2017. He became Fellow of Anatomical Society in year 2019, and his research area is on human neuromuscular junction in health and disease. His current roles are that he is member of ISBSE and he is involved in preparing the question papers and assessing the quality of question paper of MRCS Part 1, Part A examination. And he is examiner of anatomy and deputy lead for anatomy BCA course in MRCS Part B examination. He also holds postgraduate surgical anatomy education for University of Edinburgh and Scotland, and also for Royal College of Surgeons of Edinburgh. We welcome you, Ross. And now I present before you Dr. Ross Jones. Dr. Ross, I have given you request to unmute yourself. Now I present before you Dr. Ross Jones to present her lecture before this August gathering. Welcome.
Many thanks for the very kind introduction there. I'll just share my screen. Okay, I hope everyone can see my slides and my laser pointer okay.
Yeah, it is visible.
That's great. Thank you very much. Well, I'd just like to start by thanking the organizers for the very kind invitation to speak. And it's great to be in such a good company. It's a fantastic looking program over the 3 days. I note it's 2 p.m. in India. It's just gone 8:30 here in the UK. So I'll be talking today about improving surgical training and establishing a surgical anatomy program in Scotland. So really what we're hoping to do is to share our experience with the program to date in terms of the rationale for setting up the program, some of the challenges that we've faced in getting the program off the ground, and then we'll focus on some of the trainee feedback. Particularly, we want to highlight some interesting insights that have come out of the program, and then we'll finish really by asking the question, what next? Clearly, we're living in uncertain times, and it's not entirely clear how things will be post-COVID. So in terms of the background then, well, we'll all be familiar with the changes in the undergraduate medical curriculum that have occurred globally. In the UK then, there's really two initiatives that led to these changes. First of all was Tomorrow's Doctors, which was a General Medical Council initiative in 1993, so some years ago now. And that was closely followed by Modernising Medical Careers from the Department of Health a few years later. Clearly, there have been a lot of changes. There have been many advantages to the changes. There have been many disadvantages. Our remit for today, we're not really going to get into the undergraduate medical curriculum. No doubt this has been discussed at some of the other sessions over the weekend. But I think that come what may, there's no doubt that these changes have had a major impact on postgraduate surgical training. And certainly what we find is that many trainees do struggle with the upskilling in anatomy that's required on a day-to-day basis and to support their surgical career. And certainly this has been reported multiple times now by training deaneries throughout the UK. So there's definitely an impact on postgraduate training. And certainly this problem is also recognised by the Intercollegiate Committee for Basic Surgical Examinations, the ICBSE. This is the committee that's responsible for the membership examination. For those of you who aren't familiar with the membership examination, there are two parts to the exam. There is a Part A MCQ paper and a Part B OSCE. This used to be the Viva. And in terms of the difficulties with anatomy here, this has been addressed by the ICBSE by a recent increase in the number of anatomy questions in the Part A paper. And these have gone up from 45 to 75 out of 180. So really highlighting the importance of surgical anatomy to surgical training, and also acknowledging the difficulty that trainees are having with anatomy, but also the importance of getting up to speed with the anatomy. So how does surgical training look in the UK? Again, I appreciate the audience. Some of you may not be familiar with how surgical training works in the UK, so I thought it would be quite useful just to give an outline here. So following medical school in the UK, this is 5 or 6 years, depending on the medical school. At that point, the junior doctors then enter what I term the foundation years. Now, these are designated FY1, FY2. In old terminology, we would say this is the pre-registration house officer year and then the first senior house officer year. So this is a 2-year program, and the junior doctors have a general training in medicine and surgery. At that point, if they wish to pursue a career in surgery, they will then enter, it's competitive entry, but they will then enter what is termed the core surgical training program. This is CT1, CT2, and the old terminology here was the senior house officer years. So these are themed programs. They last 2 years, and all the trainees acquire a general training in surgery. And during this time, they have to sit and pass the membership of the Royal College of Surgeons examinations to allow them to enter higher surgical training. I've put this group of core trainees in a box here because this is the group that we are particularly interested in the talk today. And the CT1, CT2 years have recently been reimagined in an initiative called the Improving Surgical Training Pilot, which feeds into the CT1, CT2 years. And we'll say a little bit more about this shortly. But this is our major focus for today. After core surgical training, then, trainees, again, it's a competitive entry into higher surgical training. These years are designated ST3 to ST8, and these are the specialty registrar years. These are up to 6 years, depending on the subspecialty, but this is essentially the subspecialty training. And during this time, the trainees then must pass the exit exam, the fellowship exam, and also achieve their certificate of completion of training. And at that point, the training is completed and they can enter independent consultant practice. In the UK, this training continuum then is overseen by the various training deaneries. So for this core group of trainees then, the question is, what options do they have at the moment in terms of postgraduate surgical anatomy? Well, in fact, it's actually relatively limited. So certainly the surgical royal colleges of the UK and Ireland do feature anatomy courses as part of many of their surgical courses. And certainly we've worked very closely with the Royal College of Surgeons of Edinburgh to develop a program called the WADE program in surgical anatomy that we established in 2012. And this is it's a continuum of learning which supports trainees all the way from the affiliate level. So this is from the senior undergraduate years all the way through to membership, fellowship, and then continuing professional development. Of course, the Royal Colleges are principally responsible to their membership. So although these courses are very well regarded, we can't regard this as inclusive teaching at the deanery level. At the deanery level then, again, there is very little postgraduate surgical anatomy provision at the moment. Possibly the best example in the UK to date has been the London Core Surgical Anatomy Programme, which is currently run from Imperial College London. But that's probably the best example. Not too many other examples up and down the UK, and certainly so far nothing in Scotland. So I mentioned a couple of slides ago the Improving Surgical Training pilot. This was a UK-wide pilot that was launched in 2018. And the essential thinking here is to try and improve the balance between service delivery and training. And one of the features here is the integrated use of simulation as an adjunct to the clinical apprenticeship. So in this schematic here, shows some of these initiatives in the IST pilot. So here we have the CT1, CT2 years, and for example, there's a surgical boot camp, monthly teaching days, laparoscopy practice, and so on. And essentially, we were approached by the Scotland Deanery to see if we could put together a surgical anatomy program to complement the other elements of the IST pilot. So that's where this program that we'll describe fits in with the training. Just a bit about the Scotland Deanery then. Well, the Scotland Deanery is a very large deanery. We've got the scale bar down here, so we can see it's quite a large deanery then from north to south. How is the deanery split down? Well, it's divided into an east sector, which we can see here in light green, and a west sector in dark green. And the dots on the map represent the individual training hospitals that the trainees rotate round. So there are 14 hospitals in the east sector, 16 in the west sector. And essentially the way the training rotations work, the trainees are allocated either to the east or the west sector, and they undergo 4 6-month rotations across the 2 years. In terms of the anatomy program that we put together, well, this was delivered centrally in Edinburgh, so trainees were having to commute to Edinburgh for this program. And the average commuting distances, therefore, were an important aspect to consider, given how wide the deanery is from north to south. So about 55 miles average distance from the west to Edinburgh, 75 from the east, because of course there are some more peripheral outlying hospitals here. So the trainees were having to commute some distance to Edinburgh. What about the breakdown of the trainees then? Well, if we pool the trainees across the 2 years, there are at any one time about 90 trainees. So it was a cohort of 90 trainees. This pie chart here shows the intended specialty of the trainees. Now, this is not set in stone, but these are the specialty intentions that the trainees have stated at the beginning of their training. So in red, we've got general surgery and the various subdivisions. So for example, upper GI surgery, breast colorectal transplant. And about 40% of the trainees then are intending to complete in general surgery. In grey then we have the other subspecialties. So for example, plastics, about 10% of trainees, neurosurgery, 1%. So a good mix of trainees, but the majority then general surgery. So what about the methods then? How did we actually put the program together? Well, this gives an overview of the program that we've delivered to date. So we've had 2 years of the program. The first year was calendar year 18-19. The second year was calendar year 19-20. The third year, which has been postponed because of COVID, I'll say a little bit more about at the end. I should just say to start with that trainees rotate in August. So the calendar here begins in August and then runs through the year. So if we start with the first year of the program, then each of the letters here represents an individual training day. And in the first year of the program, we delivered 3 what we called general days. We then delivered 3 what we called specialty days. And then there was a revision day in a bit later in the year. So the general days then, these were 1-day reviews of anatomy. And these were broad overviews of the whole body to MRCS level. And all trainees attended one of these days. So there were 90 trainees in total. We could accommodate about 30 trainees per day. So we had to run 3 rotations of these days. Later in the year then, when we came to the specialty days, again, these were 1-day reviews, but this time these were more detailed reviews of the surgical anatomy of a specific region. And we divided these days then into head and neck, trunk, and limbs. And essentially, trainees could then pick one of the specialty days that was most aligned with their career intentions. So for example, ENT trainees would likely pick the head and neck day. We then had a revision day that I'll say a little bit more about later. So following the first year delivery and the feedback from the trainees, one of the key elements that came out of the feedback was that trainees would have preferred, if possible, to have attended each of the specialty days. So when it came to the second year of the program, that's what we essentially delivered. We decided to leave the general days, but simply deliver 3 rotations then of the specialty days to allow all the trainees to attend all of the specialty days if they wanted to. I've also just included here the MRCS examination diets, the Part A and Part B, just for reference. It would have been nice to have tried to tie these days in with the Part A and Part B exam, but the dates here were dictated more from the central deanery requirements in terms of other commitments that the trainees had. What about the teaching days themselves? How are they structured? Well, here I've shown the general or the timetable for the general day and then the timetable for the specialty day. So for the general days, then all of these days, I should say, began at 10 a.m. just to allow trainees time to actually commute down to Edinburgh, and we looked to finish the sessions at about 4:30. So the general days then began with a principles type lecture, which we'll say more about shortly, and then this was followed essentially by 3 teaching sessions of 90 minutes. So we set this up as a rotation of 3 tables, each table 90 minutes. For the specialty days, then again, they started at 10 a.m. They began with a principles lecture. The specialty days were then broken down into 4 teaching sessions of 1 hour. So we had a 4-table rotation of 1 hour. The lectures themselves then were not didactic lectures in anatomy. They were very much principle based and based around surgical cases. The practicals, which we've called teaching here, these were essentially interactive demonstrations on prosected material, with plenty of opportunity for the trainees to ask questions, very much like an anatomy clinic. In terms of staffing then, well, the staffing for the practical sessions then, well, we have 3 tables for the general days, 4 tables for the specialty days. We tried to, we made sure we had the same balance of faculty across each of the days. So we ensured that there was always 1 intercollegiate examiner present, 1 surgical demonstrator, and in Edinburgh, the surgical demonstrators are trainees at the CT1 or 2 or equivalent level. So this enables some peer teaching as well. The surgical demonstrator post, they are involved with the surgical anatomy teaching, but there is also a research component. And then the rest of the staff came from our in-house academic staff. So for the general days, then we have 3 members of faculty, and we could accommodate up to 10 trainees per table. For the specialty days, 4 members of faculty, then 7 or 8 trainees per table, based on being able to take 30 trainees per day. What was the syllabus that we were working towards? Well, we used the intercollegiate committee for basic surgical examination syllabus, and it was the intercollegiate MRCS exam syllabus. And this shows just a recent copy of the syllabus. Here then, anatomy, or applied surgical anatomy as it's described, features under Module 1, Basic Sciences. The supporting texts then, we recommended that the trainees use, and likewise all faculty, use Last's Anatomy for reference, and then we also use Clinical Anatomy by Ellis and Mahadevan. Last's Anatomy is still the only anatomy text that is referred to in the 10 subspecialty curricula. Lectures then, as I said before, these were not didactic lectures on anatomy, but they were very much principle based. We took the opportunity with the lectures really to discuss important aspects of applied surgical anatomy that could not be easily demonstrated in the practical sessions. And we're just giving some examples here, but topics that we covered, for example, in the limbs, we reviewed the lymphatic drainage of the limbs in a comparative sense, particularly in the context of infection and neoplasia. And then we had a side-to-side functional review of the limbs. In head and neck, this was a good opportunity to review the autonomic supply to the head and neck. And typical cases, for example, would be being able to distinguish a Horner's syndrome from a third nerve palsy. We also took the opportunity to review the lymphatic drainage of the head and neck. We've got another example here of autonomic dysfunction with a Frey's syndrome following parotidectomy. And in the trunk, again, we took the opportunity to review lymphatic drainage and applied aspects, and also referred pain, which we could tag in with the autonomic nerve supply. So, for example, referred pain in relation to appendicitis or pelvic pathology. So just some examples here, but very much principle-based, trying to cover anatomy that we couldn't cover easily in the demonstrations. And again, crucially built around surgical cases, common surgical cases. In terms of the practicals themselves then, well, all faculty were issued with these, what we call regional content guides. Now, these guides are very much based on the same guides that we've developed over many years working on the Wade program at the college in Edinburgh. We developed content guides for head and neck, trunk and limbs. I'll just focus on the limbs content guide just to show how we use these in the practical sessions. So here we've got the content guide for limbs. We've divided the limbs then into upper limb proximal, upper limb distal, lower limb proximal and lower limb distal. We've got a series of topics in each, and then each section, each of the 4 sections is then divided into, if you like, 2 subunits. And as I say, these content guides have been put together over a number of years, and they feature content that we found can be delivered in approximately equal amounts of time. So using this guide then, for example, for the specialty day, so let's say the specialty day was limbs. We've already noted that this was a 4-table rotation, with each table focusing on a different sub-region. So for example, the faculty that had been allocated table 1, this may have been the upper limb, proximal upper limb section then, and they essentially had 60 minutes to deliver all of the material here. So they're able to use this guide, for example, to divide their demonstration into 2 halves of 30 minutes. For the general days then, you'll recall this was a 3-table rotation, and this was a general review of the whole body, so head and neck, trunk and limbs. So for example, table 1 may be limbs. This time you have 90 minutes to demonstrate the material, but here you'd be actually demonstrating all of the material from the limbs. But again, the guide is helpful because you could break the units down into 4 lots of 20 minutes. Or because there were 8 units in total, then about 10 minutes per unit. So the guides were very much used to plan the sessions, but also to make sure that the faculty were delivering equivalent material to the same standard. So what about the trainee evaluation? Well, following each of the training sessions, then we asked the trainees to complete an evaluation form for each of the teaching days they attended. And to encourage feedback, then we issued a certificate of attendance for the trainees' portfolio for each of the evaluation forms that they completed. And they could use this for their annual review of competence progression, so their annual review. So we had 8 questions. The first 5 then were quantitative questions, which we assessed with a 5-point Likert scale. And then we had 3 free text questions. So the questions then, number one, the level of teaching was appropriate for the MRCS examination. Question two, the introductory principles lecture was useful. 3, the prosected material was of a high quality. 4, the day was structured appropriately to maximise learning. 5, the Edinburgh location was suitable for deanery-wide teaching. And then the free text questions then, aspects of the teaching programme that they found particularly helpful, recommendations for changes or improvements to the programme. And then the final question, are there any specific procedures where you feel a targeted review of the relevant anatomy would be particularly helpful? So we collated all of the feedback from the trainees. So what about the results of the evaluation to date then? So here we've got some basic information about the feedback and the attendance. So here we've got the year one teaching dates here and the year two teaching dates. In year one then we delivered 3 general sessions, 3 specialty sessions, and then a revision session. I should say that the revision session, this was an optional day. The trainees could come along, and it was an opportunity to review pro sections from all of the regions that they'd studied to that point. And it was essentially a self-study session. There were members of faculty present throughout the day to troubleshoot and ask questions, but it was very much self-study. And then in the second year, we had delivered 3 rotations of the specialty days, so 9 specialty days in total. We had planned to run a final revision day, but unfortunately the COVID pandemic had set in by that stage. So in terms of the attendance then, across the days overall, we had just over 300 trainees rotate through these days. A good amount of feedback then, 256 feedback forms returned, so a response rate of about 80%. You'll notice that the attendance was slightly less in the latter days, but these latter days were essentially catching trainees that were not able to attend the earlier sessions. But overall, all the trainees were able to attend all of the sessions that they wanted to. Having a look at some of the quantitative feedback then. So this is in relation to the first 5 questions. Got a series of pie charts here. The way we've color coded these then, in red, we've got agreement with the comments. Grey is neutral, blue is disagree. And we can see just by eyeballing the data then, the feedback, the quantitative feedback was very good for the whole program. So the trainees felt the level of teaching was appropriate for the MRCS, that they found the introductory lectures useful, prosected materials of a high quality. They felt the day was structured appropriately to maximize learning. The one that had the most mixed feedback, as we expected, was the Edinburgh location. And so there were a number of trainees who were neutral about the location, and there were certainly trainees, some trainees that disagreed with the location. They felt it was difficult to get to, no doubt because of the commuting distances. So not surprising, although perhaps more surprising were the number of trainees who were actually happy to travel down to Edinburgh for the teaching. So this is definitely something to be aware of for future iterations of the programme. Moving on to the free text comments, well, this was particularly insightful then. So this was the aspects of the programme they found particularly helpful, recommendations for change or improvements, and then this question about specific procedures. So again, I'm just showing a snapshot of the feedback here, but we had a number of comments really highlighting that the surgical focus of the teaching, this was routinely cited as a major strength of the programme. So they very much responded to the surgical focus. A number of trainees reported immediate benefits to their daily practice in terms of improved spatial understanding and 3-dimensional visualization, particularly in relation to operative work. And very interestingly, we had a number of comments from the trainees feeling that the teaching should form a compulsory part of their overall surgical teaching programme. So for the trainees' annual review, the annual review of competence progression, their ARCP, they are required to attend at least 70% of the teaching. Because the present programme in surgical anatomy is a pilot programme, at the moment this is not included in their teaching attendance. But the trainees were very much of the view that it should be part of the programme, and this is certainly in keeping with our own view that surgical anatomy is an integral part of surgical training, particularly in terms of patient safety. The question then about are there any specific procedures where a targeted review of anatomy would be particularly helpful? Well, here we're listing the top 20 most requested procedures by the trainees. We've got procedures 1 to 10 here, most requested, then 11 to 20. And just having a look at some of the procedures listed here, it's perhaps not surprising to see a lot of common surgical procedures. Not at all surprising to see the hernia repair came out as top here, followed by cholecystectomy, appendicectomy here. So common surgical procedures highlighted. What was maybe a little more surprising were just the number of procedural skills that were also highlighted. So we've got 3 in the top 10 here. So for example, chest drain insertion, central venous access, surgical airway. So it might be that overall then, these procedures here are reflecting core competencies that are expected of the trainees for their annual review, but it may also reflect the general levels of confidence in anatomy. The trainees are clearly coming from very different backgrounds, different medical schools, and they will have had different experiences of undergraduate anatomy. So for example, considering anatomy in relation to chest drain insertion, maybe anatomy that we'd feel is quite straightforward, well, the trainees don't quite see it that way. So just in the last 5 minutes then, well, what next? I've left this relatively open-ended because, of course, it's impossible to know the impact of COVID-19 in the long term. The IST pilot was designed as a 3-year pilot, and we were about to deliver the 3rd year of the programme, which unfortunately we've had to postpone because in the University of Edinburgh, we've had to go to, as many places, we've had to go to remote working. So that part of the programme has had to be postponed. Again, it remains to be determined what will happen with the return to cadaveric work. But I think in terms of the programme we've put together and the feedback to date, we've certainly shown that the current programme can form a model for surgical anatomy at the core training level. We've seen some very interesting suggestions for areas for improvement, particularly in terms of targeted reviews of specific procedures. These procedures are covered as part of the teaching, but perhaps this is something that could be a way in which the program could be extended, or specific teaching days. And certainly the core program now forms a foundation for higher surgical trainees and looking at subspecialty training days. And this is certainly some work we've begun to have a look at. And I'll just finish with highlighting some of this work. So you can find this on our Anatomy at Edinburgh page. This is our Edinburgh Surgical Anatomy series. So our core programme forms part of this series, but also these higher surgical training subspecialty days. And the way we've put these together then, these are cadaver-based practical simulations based around key index procedures that are of interest to higher surgical trainees. The model we've used so far then has been to begin with an anatomical review, so a lecture, a demonstration often on newly created prosections delivered by an anatomist, and then the trainees get operative practice on fresh frozen material, which is delivered by our surgical colleagues. So this is very much a joined up approach here, linking surgical anatomy and surgeons and surgical training. And so far to date, we've run successful pilots in breast surgery, trauma and orthopedics. And the next plan would be to expand this to other elements of general surgery. So just in finishing, I'd like to, of course, acknowledge the conference organisers again for putting together a great programme. Putting together a programme like this is a huge amount of work from a lot of people. So the University of Edinburgh, I'm particularly grateful to Tom Gillingwater and Jeremy Mortimer, all of our in-house academic staff and our technical team. In the Scotland Deanery then, Mr. Sathish Yalamarthi, who's the Training Programme Director for the East, Mr. Mark Veller, Training Programme Director for the West, along with all of our surgical demonstrators and trainees. And I'd also like to extend particular thanks to my colleagues at the Royal College Edinburgh, Emeritus Professor David Sinclair and the current Wade Professor Gordon Finlater. Thank you for listening. I'd be delighted to take any questions now. And also, if there are any unanswered questions, please do feel free to drop me an email. I'd be delighted to hear from you. Again, thank you very much for listening.
Thank you, Ross. Thank you very much for giving such a lucid detail of the surgical training program that you run. And we are sure that many amongst us have received insight, and they must be more than willing to start such program at their own setup. Now, I would like to invite Dr. Anita Tuli to take charge of the session. Please, Dr. Anita Tuli. Ma'am, you will receive a request to unmute yourself. Ma'am, you have been, yeah, thank you, ma'am.
I must thank Dr. Ross Dons, giving us a crystal clear program how they were managing at the Edinburgh. I was more interested in it because my son is also in UK. So I wanted to know what type of surgical training and what do they give in the NHS and how they teach. It was really a good this thing. And in the chat box, there are no questions, I think, from the audience. Any questions? I can't see any questions in the chat box. So I have a question. Do you give certification for this also, for your program?
Yes, we do. We issue certificates. These are from the University of Edinburgh. It's an acknowledgement that the trainees have attended the training, and the trainees like these for putting into their training portfolio. So this forms part of their portfolio, so they can use this for their annual reviews. So evidence that they've engaged with training. But as I mentioned in the program, unfortunately, at the moment, because this is a pilot program, this does not count towards their training, but they can still use this as evidence that they've engaged with CPD.
Who selects the cases, surgical cases? Like you said, they are given the frozen prosections also to operate on. So what type of frozen parts they are given?
So the fresh frozen material, this is in terms of the higher surgical training subspecialty days. So that's I just touched upon that towards the end of the session. For the core program, then all of the demonstrations are on formalin fixed specimens. So these are prosections, and the sessions there are run as interactive demonstrations. But for the higher surgical training days, so we've had pilots in, for example, breast surgery, trauma, orthopedics.
What do they do? Operative procedures on frozen prosections or whatever it is?
Yeah, sure, thank you. So it depends very much on the key next procedure. So if we take, for example, breast surgery, one of the key procedures is latissimus dorsi flap reconstruction. So for example, we used fresh frozen trunk material, and they were able to essentially have a simulated practice of an LD flap reconstruction.
So how do you get these material?
This is part of our body donation program in Edinburgh.
Okay. That is a cadaveric, that means.
Sure, okay.
It was a really very good and very nice elusive talk. We enjoyed it. Thank you very much.
Thank you.
Thank you very
Any
much.
other question? Yes.
Thank you very much, Dr. Anita Tuli. Thank you, ma'am, for sparing your precious time to chair the session. It was indeed a pleasure to have you with us, ma'am. Thank you, ma'am.
Thank you. Thank you, Ross.
Thank you, Dr.
Pleasure.
Ross.
Thank you
for being with us. And on behalf of Team IVACON, to show our gratitude, I want to present a certificate of appreciation to you.
Thank you.
And I will soon mail the certificate to you, Ross.
That's very kind. Thank you very much. Thank you.
Thank you so much. Thank you so much. Now, after this, we come to the last speaker of this session. We have with us Dr. Atul Gaur. Dr. Atul Gaur, just a minute. Dr. Atul Gaur is a consultant anesthetist. So sir is a consultant anesthetist at University Hospital of Leicester, And he is an author, researcher, entrepreneur, inventor, and his hobbies are medical photography and trekking and cooking. That was great to know, sir. He graduated in medicine from Gandhi Medical College, Bhopal, and he did his post-graduation in anesthesia from the very same college. Then he joined the Department of Anesthesia and Critical Care Medicine at SGPGI Lucknow in the capacity of a faculty, and then he remained there as additional professor. Then he left for UK and he joined the University Hospital of Leicester in year 2002. And till date, he is serving there. And his special interest is in regional anesthesia and innovation and development. He has described few new nerve block techniques. He has described a safety sign, light sign, for performing peripheral nerve blocks. He has also built a purpose-built device for performing ultrasound guided intervention and needle guides. Sir has received a Commonwealth Fellowship for Cardiac Anesthesia in year 1995, and he has received honorary fellowship also from FRCA by Royal College of Anesthetists in year 2013. He has written a book on sonoanatomy for anesthetists, which has won the most promising book award by BMA, and is one of the best-selling anesthesia book, which is published by Cambridge University Press. He regularly organizes workshops, courses, and conferences at UHL NHS Trust, Royal College of Anesthetists, AAGBI, Royal College of Physicians, societies and institutions in Europe and India. We welcome you, sir.
Thank you. Thank you very much. I'm going to share now my screen and then we'll start. Thank you, Professor Chopra.
So over to you, sir, now.
Can you see my slideshow, please?
Yes.
Thank you. Thank you, Professor Tuli, and thank you, Professor Sharma, for chairing this session. Thank you, Professor Chopra, for inviting me. I'm delighted to be on this conference. Basically, I'm from Lucknow. I claim that I'm from Lucknow because I worked in SGPJMS for 15 or 16 years. I'll be talking about sonoanatomy. Yes, Professor Tuli, I stayed in Lady Harding as well for 1 month or so before joining GB Pant Hospital for my senior residency in 1987-88. Lady Harding is a beautiful place. And then I've been to KGMU, Professor Sharma, and then where I was associated with one study as well about ultrasound for serratus anteplane block. Let me move this there. Okay. So namaste all attendees. I would like to thank the organizers of IVACON for inviting me, and then it is wonderful program. I have attended most of it. Today as well, I'm attending the sessions since 6 a.m. here in England. By profession, I'm an anesthetist, and we deal with perioperative medicine and interventions in our day-to-day practice. At SGPJMS in around 2000, Professor Rajan Saxena, a liver transplant surgeon, he started using ultrasound machine in perioperative area in theater complex, and that introduced ultrasound to me. And then subsequently, my wife, Vandana, who was a senior resident in radiology there, she practiced her Doppler on my neck. It was a bit of discomfort, but then I found ultrasound, amazing technology which can see structures inside the body. So in our talk, in next few minutes, we will be looking at how sonoanatomy helps us in dealing with complexities of upper limb nerve block interventions. I will use example of brachial plexus block and then discuss about other peripheral nerves, how peripheral nerves appear on ultrasound and how to track them, differentiate them from other adjacent structures. You all are masters of anatomy, and then you know more about morphology and anatomy. But then just a few words. Morphology comes from ancient Greek morph word, meaning form or shape. It's the study of shape and is an integral part of anatomy. Anatomy is oldest scientific discipline of medicine. The first documented scientific dissection on the human body are carried out as early as 3rd century BC in Alexandria. Anatomy comes from anatomeme, meaning cut open. Anatomy provides us knowledge base through cut open or dissections and naked eye examination that helps to understand the inside of human body and forms the foundation of medicine. Vesalius described what he observed during the public dissections of human corpses in later, and then with his comprehensive scientific studies of human bodies, he revolutionized the anatomy. So a bit of knowledge about morphology and anatomy. Then ultrasound. We all know that Spallanzani performed studies on bats that concluded that bats could navigate using sound rather than sight. But then ultrasound basically started coming in clinical use during and shortly after Second World War. From the mid-60s onwards, the advent of commercially available systems allowed the wider use of ultrasound. And first ultrasound guided nerve block was described by professionals in Vienna. Ultrasound is a technological advancement that allows us to see structures in real time and with improved vision. It takes care of anatomical variations like we discussed during the conference and reveal exact arrangements of the tissues in real time. First report of using ultrasound to evaluate peripheral nerve published in late 1980s. During our ultrasound workshops, which we conduct for past 12 to 14 years, we go back to dissection room, revisit the anatomy, and then correlate the morphology with what we see on ultrasound. Professor Jyoti Chopra and Anita Rani have actually conducted our cadaveric prosection sessions in Lucknow and in Jaipur. Anatomy is very important. It provides us a sound foundation and knowledge base. Before starting using ultrasound, whenever I used to see brachial plexus, this picture came in my mind. And when I looked at the images, I learned that nerves, brachial plexus starts from neck and then they go into axilla while giving few branches. I also learned, remember to drink cold beer, roots, trunks, divisions, cords, and branches. That was the impression I had. Now I know that brachial plexus is basically have got various arrangements inside the body. When I look at the ultrasound, it is not as simple as we can depict here in this diagram, that a straight line is starting from neck, goes to axilla, and then you can approach brachial plexus anywhere there. But then human anatomy is more than that. In 2004, when I started using ultrasound for nerve blocks, everything changed. Now I was more concerned about the nerve supply, dermatomes, and myotomes as far as theoretical knowledge is concerned. But otherwise, I was interested in learning the anatomy, looking at the pictures, that how they look like, what is the arrangement, from where I can approach them. Both persons in this picture are my colleagues. Pictures show ultrasound probe placement for supraclavicular approach. There. I have also described a lateral position for putting in supraclavicular nerve block, because this helps operators to approach the supraclavicular brachial plexus. He can then comfortably place the catheters, and patients are also comfortable in lateral position, and then they can watch the procedure on ultrasound themselves. So they feel more reassured. They don't feel like that a needle is being inserted into their neck. We are going to use the example of supraclavicular brachial plexus block initially. When we place ultrasound probe in supraclavicular fossa here, we can see the arrangement or internal morphology. We call it sonoanatomy of brachial plexus. Brachial plexus looks different to me, always. Each patient is different. I have never seen two brachial plexuses mirror image to each other in patients. In many patients, say for example, in a month, if I do 10 to 15 brachial plexus block, no two brachial plexus are same. So when we see a particular pattern, that's how we used to recognize. We used to call it pattern recognition. We put ultrasound probe there and then see bunch of grapes or kind of a honeycomb appearance or a traffic light sign for interscalene brachial plexus block. And that's how we used to recognize these structures when we started using ultrasound into a practice in 2004, 5, 6. Subsequently, we learned that there's more to it. This slide has got two videos. Let me stop them and then I will explain. Okay. So they are the example how supraclavicular brachial plexus appear on ultrasound. Here you can see this shape. Here in another patient, you can see this shape. They both are different. Here you can see pleura here and pleura there. And here you can see bone, rib here and pleura there. So always there's a different arrangement. I'm using and teaching ultrasound since 2004-5. And as I mentioned, I have rarely found same nerve in similar pattern in two patients. Obviously, our learning from cadaver anatomy provides us foundation. But tell me honestly, do we remember these anatomical variations which we learn in our anatomy classes or dissection room? And can we predict that a particular variation is present in a particular patient? I think we should use probability pattern recognition and start recognizing these structures based on probability, make a pattern of them on real-time imaging. That is, make a decision and see structures on the basis of probabilities. Probability pattern recognition while scanning in real time in a particular patient helps us. I'll play now these videos and then we'll explain to you. So that is skin over there. If you can see my cursor, skin over there. And here you can see carotid subclavian vein. And here it is subclavian artery in this video. You can see the arrangement of brachial plexus. You can see a few hypoechoic areas as well there. They all look hypoechoic areas. When we will explore them further, we will know about the adjacent structures. Now my probe in this movie has moved anteriorly onto the neck. You could see the internal jugular vein there. I'll freeze it there. Okay, here you can see internal jugular vein over there. You can see carotid artery there, sternocleidomastoid muscle there, antiascalene muscle there, and on top of the antiascalene muscle, you can see the phrenic nerve. So that is what is sonoanatomy. Sonoanatomy gives us a picture as if you are seeing it in dissection room. But because patient is alive, we can't dissect them too much. This especially helps when we perform minimal access surgeries or percutaneous interventions, that we can see these structures inside so that we can make our procedure safe. Here you can see interscalene arrangement of the brachial plexus. Let me freeze it here. Okay, here. So here you can see interscalene arrangement of the brachial plexus. That is the antiascalene muscle. That's the middle scalene muscle. Here comes the sternocleidomastoid somewhere there. And if you remember the book picture of interscalene muscle, then you will remember that there is a vertebral artery there. But when we do ultrasound guided procedure, we see subclavian artery there, which is very big. And then we can see pleura as well. So when we do procedure, we need to be careful that our needle is not overshooting. This looks big on the screen, but then this is just 1 centimeter there, 2 centimeter there, and 2.5 centimeters. So that means that this distance must be somewhere around 1 centimeter of the needle. A needle can travel very quickly to these areas if we are not careful. So sonoanatomy helps us in knowing the structures or internal morphology in real time. Then, because we can do now ultrasound, now we will not see nerves only. We see other structures as well. And then we start recognizing them. And therefore, once again, probability pattern recognition improves our vision, and we start seeing the internal morphology more accurately on ultrasound, that is sonoanatomy. And this is of great importance when we do interventions. We all know that nerves travel together with the vessels. Here in this picture, you can see transverse cervical artery or thyrocervical trunk going across the brachial plexus. Often it goes within the brachial plexus. You can see various veins as well over there, and a bone, and then the pleura over here. These structures I never saw when I was performing brachial plexus block before using ultrasound. Regional anesthesia is my favorite topic. I'm using too much of regional anesthesia techniques that I learned at Gandhi Medical College, Bhopal. But then we came to know about the complications or the puncturing the vessels only when there were complications, only when patient presented with complications. A proper knowledge of sonoanatomy and use of ultrasound gives us insight to see these structures, and therefore we can avoid any insult to them. Let me stop this video and then I will explain. A bit about color Doppler during real-time ultrasonography. Color Doppler doesn't always show colors, so we should know that. In Doppler equation, cosine 90 is 0. That means that when probe is placed right on top of the vessel, perpendicular, then at 90 degree, then it won't show any color. And their probability pattern recognition helps us in recognizing these structures. Now I will play this video and then we'll explain what I mean. So here you can see internal jugular vein, carotid artery. Here you can see subclavian artery. When we put on color Doppler, you can see this is the brachial plexus, and thyrocervical trunk or transverse cervical artery is passing through. On this area, you can see the veins, and our needle will enter in this direction. So when we start recognizing such hypoechoic structures, we can recognize them as a vein. So if I freeze the video here, when it comes as a grayscale imaging, then I'll show it to you. But what I mean, I'll go further. Yeah, stopping here. So you can see that is the brachial plexus, subclavian artery, and in this structure and this structure are in fact arteries. They're not brachial plexuses like this. They look similar. So therefore, we should now predict that what structures can be there. We should take care of color Doppler to recognize them. And then we should know the weakness of the Doppler as well. That color Doppler not always shows color, because when waves are falling at 90 degree, it won't show any color. So therefore, we should start thinking that these pulsations are not, sorry. Okay, so these pulsations are not conducted pulsations from the subclavian artery. They are the separate vessels. And that's how sonoanatomy helps us in performing blocks more safely. Then comes the psychomotor skills. We were discussing about psychomotor skills and dexterity in previous talks. Understanding of sonoanatomy and real-time visualization helps in making interventions safe. As we can see vessels and other structures such as pleura. But these nearby structures can sometimes frighten us, because when we are doing landmark guided technique, we don't see these structures, and therefore we are not bothered about them too much. But then when you can see the artery or a vein or pleura, then you are very, very careful that, oh my God, how I will take my needle in there, because inserting needle is not very simple as well. Tissues slip away. So therefore, then I thought of a technique which I called CombiTech ultrasound guided needling, which is a combination of landmark and ultrasound guidance. So we create a landmark using ultrasound, and then we take needle inside the body under real-time ultrasound guidance. So here in this picture, you can see we have put ultrasound probe there to see the brachial plexus inside. Then we apply little pressure with the help of probe after finding a safe plane, and lift the probe, and then to create a rectangle, a blanched rectangle, which you can see on the image. And then take needle inside, right in the center of that blanched triangle, superficially, subcutaneously. Then put our probe back, and then take needle inside into the deeper plane safely. I will explain this through a video. And here you can see, you can see brachial plexus arrangement there. You can see the same picture which we described earlier. The brachial plexus is here. Okay, subclavian artery, vein, a valve there. Then after evaluating and then finding out on Doppler that what is the safe plane of needle insertion, Here we go. So finding out these vessels, adjacent vessels, I'm using same picture so that you can recognize these structures. Then lift the probe, then you won't see anything, and then place back probe again to see whether that blanched rectangle represents truly your safe plane of needle insertion. Needle will come in this area. Again, lift the probe, create a blanched rectangle on the skin, insert the needle subcutaneously in the meantime, then put your probe back and locate the needle in subcutaneous plane here, and then perform rest of the procedure under ultrasound vision. Here you can see that it is not simple to introduce needle. These fascias, they move your needle away. They are tough. And then this subclavian artery is very nearby, so you have to be very careful. Once you locate your needle tip near the brachial plexus, then you can start injecting local anesthetics. So a combi needling technique can provide you a safe needling method to introduce needle in a safe plane quickly. Now, here in this picture, you can see this needle looks as if it has entered the nerve. This may be a mirage, an illusion. It is not always the case that when you can see needle going into the nerve is in fact has punctured the nerve or impaled the nerve. And therefore, we should know about the artifacts as well on ultrasound. Here in this picture, you can see a section thickness artifact. The ultrasound probe, ultrasound wave as yellow in color. And if object is here, say for example, this is a brachial plexus and a needle nearby, then you can see this needle as if needle is overlapping the brachial plexus onto the screen, like you can see it here. While when ultrasound waves are in this shape, then you can see both structures separate. But then once again, when ultrasound waves starts scattering in adjoining area, then it will give an appearance as if needle has gone inside the nerve again. So how to differentiate it? It is very worrying. If you can see a picture like that on ultrasound, you cannot start injecting local anesthetics. And that has led us to describe glide sign, about which we'll talk very soon. But then here in this diagram, you can see that needle has gone inside, and then this local anesthetics is getting deposited there, while here needle is extraneural, and then local anesthetics, which is blue in color, is depositing outside the nerve. Ideally, when we perform nerve blocks, we look for this situation. But then when needle accidentally goes in, then because volume of injected is too much, about 10 to 40 mils, this will cause injury to the nerves, complications. We know that intraneural injections are also helpful, very useful, but then only in hands of experts and with very low volume, 0.5 mils or so, while monitoring injected pressure continuously. So therefore, accidental intraneural injections can cause nerve injury, and therefore, conventional wisdom holds that accidental intraneural injections should be avoided at all costs. Here in this picture, you can see nerve, and here you can see the nerve when intraneural injection is made. You can see already the injury to the nerve over there. So we should avoid this accidental injection at all costs. How to do that? That's why we described a glide sign, because we were involved in teaching and training and then doing procedures ourselves. So we were reviewing our images, which we used to obtain for our workshops and courses. And we found that needle tip is outside the nerve. And when you move the hub of the needle up and down, then needle will roll over the nerve. But when needle has impaled the nerve, and then if you move your hub outside the needle, outside the body, then with needle tip, nerve will also move. And this is one of the ways to know where needle tip is located. In chronic pain procedures, many times you want to introduce needle inside the nerve, or when you are putting an intraneural nerve block, you want to put a needle inside the nerve. A glide sign helps you in knowing that your needle tip has gone inside the nerve. Or when you're doing extraneural injection, before starting depositing local anesthetics, you can quickly perform the glide sign by moving your needle hub up and down, not in and out, up and down. And then if it is outside, it will roll over the nerve. and then deposit local anesthetics. It can enhance the safety. Here in this video, you can see the same thing. So that is the nerve, and you can see that needle is outside nerve, and when you move the needle hub, which is outside the skin, then you can see that needle is going away from the nerve. It is not dragging nerve with it, it is rolling over. And that is what is glide sign to perform. So sonoanatomy, or visualization of what is happening inside the body while you are performing procedures, provides us a opportunity to see many such things. Ultrasound also helps us in evaluating the procedure. Say, for example, in this video, you can see needle is near the brachial plexus. Then we deposited local anesthetics, which in a way dissect the whole area. Then we advance our needle, and then we move our needle around the brachial plexus so that we can deposit local anesthetics properly. After that, we can move our probe anteriorly, that is internal jugular vein, carotid artery, that is anterior scalene muscle. I'll stop here. That is anterior scalene muscle. And then we can see the spread of local anesthetics here. Even when we deposit less amount of local anesthetics nowadays, during ultrasound guided procedure, we can still see local anesthetics spread anterior to anterior scalene muscle, where phrenic nerve lies. And when local anesthetics bathe the phrenic nerve, it can paralyze the diaphragms, which is very important for us to know. Previously, we were thinking that the volume of local anesthetics, when we inject 30-40 mils, it breaks the physical barriers and comes anterior to the anterior scalene muscle and then spreads in this area. But while reviewing our ultrasound images, we found that this is one slip of anterior scalene muscle, another slip of anterior scalene muscle, another slip of anterior scalene muscle, and you can see these channels. So local anesthetics, even when it is less in volume, can travel through these loose channels, which are inside the belly of the scalene muscle. This is unpublished thing. But then we have reviewed many images, and we found that when volume of anesthetics is low, then also local anesthetics can go anterior to the anterior scalene muscle. And that is because these channels are loosely arranged in those patients. And that's why local anesthetics goes. Nothing to worry about it, but then at least we need to know about these patients. And then in recovery area, we can hold them back for a few more hours so that when diaphragmatic paralysis disappears, then we can move them to ward to avoid catastrophes. So sonoanatomy helps us. Then comes another challenging issue. In certain diseases, accidents, aging process, or say for example burn injuries, they can have significant impact on external morphology. So landmarks, they don't work. Ultrasound also is very difficult then to perform. But a sound knowledge of sonoanatomy allows the operator to still visualize and perform procedures safely. What is important here is to learn that what we see in anatomy books, though enhances our understanding, is not all that helps when it comes to dealing with interventions. Sonoanatomy, and as I mentioned earlier, probability pattern imaging helps in performing procedures safely. I'll play this video. So here you can see there is a very big dip in the supraclavicular fossa, so we can't put ultrasound probe there and perform the procedure as we described. Here that is trapezius. So because ultrasound probe is there, under ultrasound guidance, we can still take our needle inside through the trapezius safely towards the target. And there, sonoanatomy or knowledge of sonoanatomy helps. So ultrasound, so anatomy provides us a very important foundation, but then sonoanatomy helps in looking at that foundation or those facts of internal morphology properly in a particular person. Next, please. Now we will move on to axillary brachial plexus after giving you some idea about how sonoanatomy helps in performing interventions or minimal access surgeries. I've given an example of percutaneous procedure, that is nerve block. Here in this picture, you can see axillary brachial plexus. That is the diagram, which is available in books. I have never seen axillary brachial plexus arrangement as it is described in books based on anatomy. It is always different. Here you can see musculocutaneous nerve, median nerve, radial nerve, and there should be ulnar nerve, which I don't see it. After depositing local anesthetics, you can see the median nerve has, that is the axillary artery, that median nerve is surrounded with the local anesthetics over there. And this is the radial nerve, and local anesthetics has gone on that side as well. And ulnar nerve is still not bathed with the local anesthetics. So in this case, then I will move my needle from here to there and deposit local anesthetics at that site as well to put in a block. Sorry about some background noise, okay? Here in this video, you can see same thing. So axillary artery, there's a vein there. When I apply pressure, then that will collapse. Then you can see median nerve on this video. I'm moving my probe up and down. You can see radial nerve, and you can see ulnar nerve there. Okay? And then that's how sonoanatomy helps. That we know that these patterns are different. They vary from each other in each patient, but still we can locate them and then take our needle there to deposit local anesthetics. So when we have a sound knowledge of anatomy through dissections, cut open, then ultrasound helps us. Another issue in performing interventions as a clinician, I find myself as a perioperative physician. We practice perioperative medicine, is wrong information available in books. Here, very well-known sites, they describe interscalene brachial plexus as anti-scalene muscle, middle scalene muscle, and probe is placed there. Winnie long back described a technique of interscalene brachial plexus block to feel for the interscalene groove and then take needle from there posteriorly and medially to reach the brachial plexus. So needle tip sits in here, but then while describing ultrasound images in our own book, Sonoanatomy for Anesthetics, we place the probe there. In fact, probe should be placed somewhere here, down there. And then that's how I describe the nook block. The probe ideally should be placed in the nook between the corner, between the head and neck and shoulder, not higher up in the neck at the cricoid level. Here you can see in this video. The probe is placed there. So that is the subclavian artery. That's anti-scalene muscle, middle scalene muscle, and interscalene brachial plexus block, the brachial plexus arrangement there. And that may be the vertebral artery. And here there is pleura. So whole teaching of our anatomy changes when we come to perform interventions using sonoanatomy in order to make procedures safe in a particular patient, because approaches, they differ. In following few minutes, I will quickly cover a few peripheral nerves and then how nerves are differentiated from the adjacent structures. Nerves, they give us a fascicular pattern. You can see here, fascicular pattern, that's a median nerve. Probe is placed onto the wrist. And then there are some tendons, which are primarily hyperechoic. When we move our probe towards the forearm, these tendons, they convert into muscle mass, hypoechoic areas with some hyperechoic patches. And that's how you differentiate them. Here in this clip, you also see that median nerve is dipping down. That shows that this median nerve is very mobile, because in certain neuropathies, median nerves become rigid. So sonoanatomy helps you in identifying some nerve disorders as well. The next picture is static. It is cropped one. You can see median nerve here, fascicular pattern. You can see tendons there, fibular pattern, more hyperechoic. Nerve is hypoechoic image, and tendons are predominantly hyperechoic images. And then muscles are hypoechoic with some hyperechoic patches there. And nerve looks like hypoechoic. So when you start doing ultrasound, you start recognizing these structures. Here probe is placed on wrist, and then probe is placed, moved towards the mid forearm. So when probe is placed onto the wrist, you can see these tendons, and then these tendons develop into muscle mass when you move probe further towards the forearm, mid forearm, and that's how you differentiate a nerve from a tendon or muscle. One way to do that. Here you can again see a picture from our book. So here you can see flexor carpi radialis muscle, then flexor digitorum Superficial is, you guys know more of anatomy than me. Then flexor digitorum profundus. You can see artery over there, hypoechoic. You can see radial nerve there. You can see median nerve there, and that is the skin. And you should remember that which side of probe is looking at the image. So this is lateral and this is medial. And that's how we describe images on sonoanatomy and recognize them. Here in this video, the median nerve can be easily differentiated from the muscle because this is predominantly hypoechoic, hyperechoic structure there. And when we move our fingers, then nerve doesn't move. It is just static, but muscles are moving. So that also helps in differentiating a nerve from the muscles on ultrasound. When we move our probe transversely in a cross section, you can see nerve as a hypoechoic or as a honeycomb appearance over there. One way of differentiating muscle or tendons from the nerve. And then here, probe is placed in long axis on wrist, and then you can see tendons, which are sometimes very adjacent to the nerves and difficult to differentiate. But then when we move our fingers, as if we are opening and closing our fists slowly, you can see nerve over there, which is hypoechoic, hyperechoic, which is not moving while tendon is moving in longitudinal direction because its length is changing. Machines are very smart nowadays. You can zoom in, zoom out. Here you can see a zoom in image of the median nerve. You can see fascicle bundles there. You can see perineurium and epineurium there. And you can see muscle over there. So you can visualize a nerve more properly. A small superficial transcutaneous nerves as well can be recognized by the ultrasonologist when they perform pain procedures. So a sound knowledge of anatomy, I'm again repeating, helps us, but then probability pattern recognition helps us in recognizing these structures in real time. If I put in Doppler probe there, then I can see some vasculature over there. If nerve is very vascular, if there's too much of blood flow, that also means neuropathy. So ultrasound helps us in differentiating some nerve disorders as well. Here you can see the probe is placed in over the humerus bone over there, and then you can see the radial nerve over there, muscles like medial head of triceps and then lateral head of triceps and brachialis over there, and that is the bone. After bone, you don't see any structure down there. You see a dropout shadow because bone doesn't allow ultrasound beam to go through, even though ultrasound speed is more in bones than in normal tissues. But then because of the acoustic impedance, difference in acoustic impedance, you don't see behind the bone. And that is what is Professor Chopra asked me to explain that how one can differentiate. When we move our probe further down, you can see the radial nerve is dividing into two, a deep radial nerve and superficial radial nerve. So you can follow the course of the nerve, and then you can select where you want to put in a block rather than blocking the whole brachial plexus. So ultrasound or sonoanatomy helps us in not only blocking the nerve safely, but then producing only selective blocks. Here we are locating the ulnar nerve, and you can see here, this picture is very good to differentiate between a vessel and a nerve. So that is the ulnar nerve over there. That is the vein. When I apply pressure, it collapses and artery starts pulsating more here on ultrasound. So you can see again, that is the skin, medial, lateral. You can find ulnar nerve over there. That is the vein and artery. When I apply pressure, vein collapses and artery starts pulsating more. And that's how we differentiate between a vessel and a nerve. Now these are a few aesthetic pictures of musculocutaneous nerve. Now you can differentiate musculocutaneous nerve from these fascias and muscles, because you know that when you move probe up and down, nerve will follow the probe, and that is the bone, because you can't see anything behind the bone. This is not a nerve, this is a bone giving a shadow, bony acoustic shadow. Here you can see again musculocutaneous nerve. You can see various muscles over there and bone. We can in fact track the nerve using sonoanatomy. So you place your probe onto the wrist and then start moving your probe higher up. And then all tendons, they will develop into muscle mass here. And then nerve will stand out very clear. So that is median nerve. We are going towards the wrist now. So nerve is moving there. You can see that how mobile is the nerve. It is diving down the tendons when we move our probe. These are the tendons, flexor tendons. And then another phenomenon which you can see in this video is anisotropy. The tendons are more prone for anisotropy. So here tendon is looking fibular and then it is looking hypoechoic. Nerves don't do that to that extent. And that's one of the differentiating features between a tendon and a nerve. As I touched upon the abnormal sonographic findings during the presentation, with the use of ultrasound, we come to know about the anatomical variants, and then we can accordingly, do intervention. In case of trauma, we can see nerve injuries, various neuropathies we can recognize by looking at the echogenicity of the nerve. It goes down with neuropathies, vascularity goes up with neuropathies, mobility goes down with the neuropathies, and nerve size increases with the neuropathies. And sometimes they talk about flattening ratio as well. Flattening ratio changes, AP diameter and lateral dimensions, they changes. So that's how we can use sonoanatomy to understand anatomy in a better way when it comes to performing interventions, percutaneous interventions, or minimal access surgery. Thank you very much.
Thank you, sir. Thank you so much for your excellent presentation, sir. It was excellent, and the videos that you used were so explanatory, and you explained the anatomy so well.
I learned from you, madam.
Thank you, sir. Now I hand over the session to Dr. P.K. Sharma. Sir, I will unmute you. I have sent a request to unmute you. Please unmute yourself.
I'm audible.
So you must, yeah.
I'm audible.
Yeah, sir.
Yeah, I can hear you.
Now you're audible, sir. I had
a big thank to Dr. Atul Gaur for giving a very comprehensive, very informative, and a very lucid talk. And if I'm not wrong, about 4 or 5 years back in a conference at Andaman, I met you, Dr. Atul.
Oh, yes, I remember, sir. Yes.
I met you there over there. We were there in the same very conference in a hotel. As far as your talk is concerned, I'm very much influenced by the fact that you talked about the glide sign. Glide sign is a very important sign which you talked about and which must be known to the anatomists, of course, to the surgeons as well, but as an anatomist, so as to teach to the other subjects. Now you see that another thing which you told about is deformity. As far as the deformity is concerned, ultrasonography or this sonoanatomy helps a lot, so that we are at a right site. You see that another point which came into my mind was that my question is that if we are giving a finger block, digit block, the nerves and the vessels are very small. Are we able to differentiate between the nerves and the vessels, or the other structures, or the tendons over there in that region? Is it possible?
Yes, sir. That is very, very possible. In fact, that is one of the reasons my surgeon, foot and ankle surgeon, always asks me before the starting surgery, can you show me, please, where are the vessels? Can you show me where are the nerves? So that, because if you remember, when we were using landmark guided technique, when I was in Bhopal, say for example, surgeons are operating, they used to stress the foot and ankle and roll over their finger to feel for the nerve, so that they can save that, because nerve rolls, finger rolls over the nerve. But then here on ultrasound, you can track the nerve. You can put a landmark or markers that this is the course of the nerve or the artery, and then they can then save them. Yes, we see, in fact, not only we can see the vessels and nerves, but then we can limit our volume of injected as well. We don't require 2 mils or 4 mils of local anesthetics for digital nerve blocks. We just require 0.5 mils. So that way it helps. Yes, sir.
One more point that I was reading in the book Rheumec, ultrasound book Rheumec. It says that the difference between the nerve and the tendon, as far as is concerned, the tendon is something like fascicular pattern, what you told. But what they say in the nerve, it is honeycomb appearance. What's that?
Yes, sir, you are right. And I can understand the difficulty in using terms by you as well, sir. So now gives a fascicular pattern or honeycomb appearance, or bunch of grapes, and that is the combination of hyperechoic, hypoechoic areas. Fascicles or bundles, nerve bundles, they look like hypoechoic, and the connective tissue looks like hyperechoic. While tendon gives us a fibrillar pattern. It is more hyperechoic than hypoechoic, and that can be the one of the differentiating point between two. Besides, tendon shortens their length when you move fingers around or foot around, and then so yes, the fascicular pattern and fibrillar pattern helps in differentiating tendons. You are right.
Yes, sir. Any questions from the audience? Are there any questions?
So if I can interrupt in between.
Yes.
Just translating that honeycomb pattern into anatomical terms.
Yes.
Right, sir. As Dr. Atul Gaur told you that this honeycomb pattern is because of in center we know that there is axon and it's surrounded by the myelin sheath. So that myelin sheath, it gives hypoechoic shadow, and the perineurium, endoneurium, and epineurium, they are giving hypoechoic shadow. So that connective tissue or fibrous tissue, that is giving hyperechoic shadow, and the myelin in between is giving hypoechoic shadow. So if a bunch of nerve bundles are there, they will give honeycomb appearance.
Correct.
So that is anatomical.
Yes, you are right. You are right, Dr. Jyoti. But at the same time, the presentation was excellent, beautiful. We learned a lot.
Yes, sir. Yes,
Any
sir.
question from the audience? We just see audience question.
So what should be the resolution of this probe for doing the digital nerve block?
Digital nerve block.
Yeah, nowadays machines are very good and very cheap, and then they are available in every corner of the hospitals nowadays. In fact, you can get a same probe with varying frequency. So we can get a linear probe, say for example, its frequency varies from 8 to 15 megahertz. So when you're looking at the deeper structures, you can reduce the frequency. When you're looking at the superficial structures, you can increase the frequency, because ultrasound decays in the process of visualizing the structures. So therefore, if you want to see the deeper structures, you need to reduce the frequency. Regarding curvilinear probes, which we use, say for example, for sonoanatomy of spine, looking at the spine, then they are the deeper structures. Then you use a probe with frequency of 3 to 5 megahertz, a low frequency probe, so that you can see deeper structures. So that, yeah, so it's like
Okay, Gaur, there is another question from the audience.
Yes, sir.
The question is, how can we differentiate between injured vessel and a non-injured vessel? There's a question. Answer is yes, you can.
Yes, if I would know the question in advance, then probably I will show a video clip as well. So when you injure a vessel during the procedure, then the blood starts coming out, and you can see hematoma formation on ultrasound immediately. In fact, when you have got ultrasound guided, you're doing ultrasound guided procedure, sometimes you can rescue the situation by applying pressure of the ultrasound probe without insulting it further, a compression for about few minutes, and that stops bleeding. But then more important is that you don't then inject any local anesthetics inside the vessel when you injure it. So you can see that, and then frequently you can see this phenomenon when you are putting in internal jugular venous catheter. If you accidentally puncture the carotid artery, you will not do more insult to the patient, because patient can have then a stroke if you continue doing the procedure. So you can apply a compression over there. Yes, you can see the hematoma formation under ultrasound.
Another question from the audience is there any drawback or the disadvantage of this procedure?
Disadvantage is that you get afraid, because sometimes it is better not to know things. So say for example, if in a jungle, we are going through a jungle, if we don't know that in jungle is a lion, then we can go through very easily. Same thing happens when we use ultrasound. So when we do a landmark guided technique, we don't realize that there are vessels and veins and then pleura, and then we just perform the procedure. We poke the needle into the nerves, and then patient says, ah, and then we say, oh, wow, we found the brachial plexus now, and inject now, without knowing whether needle has injured the vessel, needle has injured the pleura in the way to the brachial plexus, or our injections are intraneural. When we use ultrasound, you know all these things. So therefore, a good knowledge of anatomy, foundation, very important, idea about the variations so that you can have probability pattern recognition, and then how to do needling is very important when you use ultrasound. So that is the drawback. It has a learning curve. So you need to learn the technique properly. It is not like that you have ultrasound machine, hold ultrasound probe in your hand, put it on patient and do the procedure saying that yes, it is safe. No, it is not safe.
And the last question from my side, that is there any way that if an intraoral nerve block is to be given, how to give it? How to localize it, intraoral?
Nowadays, you can get different kinds of probes, sir. So, say for example, when we're doing, you can have a probe, cylinder probes. They are of different shapes, hockey stick probes or endoscopic probes. And then probably I have never done that. But then when you ask me this question, probably that can be done. Or an ultrasound probe can be placed outside and the structures can be looked inside, and you can take needle from the intraoral route towards the nerve. And you can do that because many times you can put in a subclavian vein catheter by putting probe in supraclavicular fossa, especially in pediatric age group. So you place probe somewhere else and you take needle somewhere else. So in similar way, probably we can perform the oral or dental nerve blocks.
And finally, a question from the audience. It asks you, should sonoanatomy be compulsory in the curriculum of the anatomy?
I would say further to that, yes, it should be compulsory in anatomy because it is one of the ways we can learn about the anatomy in a better way. There is no alternative of anatomy. There is no match to cut open, dissect, and then see the structures, because that gives us idea, eyeballing effect. That gives us the exact idea that how structures looks like in the body. But then when it comes to the procedures in live person, we can't cut open. So therefore, sonoanatomy helps us. So therefore, we should learn sonoanatomy right from the beginning. I will be very, very happy to get involved with a few of you who are listening, who are in the audience, to have a sonoanatomy program in your colleges. In fact, that will be my privilege. But then the use of sonoanatomy, I think, use of anatomy, I think, is very much required for postgraduate studies. So when they go, if they join post-graduation in any of the surgical or medical specialties, because interventions are done every day, they should have 3 to 6 months, at least 3 months posting in the Department of Anatomy. So it should be done like that, because we need to revisit anatomy every time when we are performing procedures. Otherwise, we forget. So I would say that for PG studies, anatomy rotation should be made compulsory.
Just to add to yours, I totally agree with you. At the same time, with the idea that if you learn sonoanatomy in the beginning, your base will be strong. So
yes,
with this idea only, I have established a unit of ultrasonography in the Department of Anatomy itself. And we teach anatomy to the UGs.
Yes, sir.
We teach anatomy to the UGs. That's why.
Yeah.
Thank you very much, Dr. Gaur.
Thank you so much.
It was a wonderful talk. We learned a lot. Thank you very much and hope to meet you again. Thank you.
Thank you, sir. Keep blessing. Thank you.
Thank you so much, sir. Thank you so much for that awesome talk. And I would say, as stethoscope for medicine, same is the role of ultrasound probe in the medicine now, because you have to see live those things. And everyone, right from the beginning, they should know the normal display of the structures by the ultrasound. So I would thank Dr. Sharma. And I know this subject was close to his heart. So thank you, sir, for chairing this session and making it so interactive also. I'm grateful to you. And a heartfelt thanks to Dr. Atul Gaur for accepting our invitation and presenting such a great talk And I think many of the anatomists are really making imaging anatomy as a career, or that is a area of interest for them. So they must have been benefited by your talk, sir. And in the end, I would like to present a certificate to Dr. Atul Gaur as a gesture of appreciation from our side. Sir, I will send you this certificate by mail soon.
Thank you, madam. Thank you very much. I felt nostalgic when I was delivering the talk. I felt as if I'm in Lucknow, great city. Thank you very much.
Thank you so much, sir. Thank you. So with this, we come to end of this CME session of this conference. And I am really thankful to Dr. Gaur, Dr. Ross, Dr. Anita Tuli, Dr. P.K. Sharma, and all our delegates who have given their precious time in making this CME a brilliant success. Thank you, sir. So now I will request everyone to move to their respective rooms for the session of poster presentation. The rooms have been assigned, and I request everyone to move to their respective rooms for their presentations. Thank you.
Thank you.
Am I audible to all?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Good evening, everyone. Am I audible to all?
Yes, ma'am.
Good evening, ma'am.
Yes, ma'am.
Yes, ma'am.
Ma'am, you're audible.
A very good evening to all of you. I hope I'm audible to all.
Yes, ma'am.
Yes.
Our lovely audience today and our amazing participants. Is that okay?
Yes.
Our
Yes,
lovely
ma'am.
audience and our amazing participants. I, Dr. Garima Sehgal, welcome you all to the IVACON 2020
Yes, ma'am.
PG quiz contest. I request all the participants to keep themselves unmuted till they are instructed not to do so. Also to keep their videos on while the quiz is going on. You will only speak on your turn, and please remember only to speak when you are asked to and when your name is called. So we'll be beginning the quiz in a matter of a minute. So here we are, witnessing the finale round of the IVACON 2021 postgraduate quiz competition. I will be your quiz master for the day. I am Dr. Garima Sehgal. Is Dr. Kanchan. She would be the scorekeeper for the quiz, and Dr. Mariam, who will watch of the time. Let's meet our wonderful 11 finalists for today. Dr. Neetu from GMC Kozhikode, Dr. Shaheen Rizvi from KG Somaiya Medical College, Mumbai, Dr. Divya Vashne from AMU Aligarh, Dr. Sangeeta Palani from RIMS Imphal, Dr. Meryl Rachel from Raipur, Dr. Nikhil Agarwal from KTMU, Dr. Devasha from AIMS Rishikesh, Bhavesh from Jodhpur, Rajasthan, Dr. Pankaj Rathi from Maulana Azad Medical College, Delhi, and Dr. Anbarasan from AIMS Bhubaneswar. I welcome you all for the quiz today. Your names have been arranged in a serial order for facilitating the sequence that we follow for questioning you. But we will still be calling you by your name, so please pay attention while your name is being called. Some rules and instructions about the quiz. There will be 3 sets of rounds of questions, set A, set B, and set C. Each set has more than one round, and the questions are mixed type from all the subdivisions of anatomy. Set A will consist of text-based questions and image-based questions. Unfortunately, at the end of set A, 5 participants, depending upon what their scores are, will have to be eliminated. Then we continue with the set B, and will again consist of text-based questions as well as a visual round. At the end of the second set, 3 participants will be eliminated from the quiz. The final set, which is the set C, will be played only by the 3 final participants. This set will also consist of text-based questions, a visual round, and a rapid-fire round. I hope all this was clear to all our participants.
Yes, ma'am.
So you will all be together in the set A. There will just be 6 of you in the set B. And I mean, that has to be like it. Only 3 of you in the last set, set C. To begin with every round, we will have one name slip picked up, and we begin the round from the person whose name is on that slip. And after this, we will follow the sequence of the names as is written there on the screen. I will be telling you about the scoring pattern. There are 10 marks for every correct answer that you give. You will be allowed 15 seconds to answer every question, and you will be scoring 10 marks if your answer is correct. There is no negative mark for an incorrect answer. So I will request you all to answer all the questions that are put forward to you. The questions will not be passed. Okay? None of the questions will be passed. The questions that are meant for you are meant for you only. Before I begin, as they all say, life is a journey with problems to solve and lessons to learn, but most of all, experiences to enjoy. So enjoy the quiz while you're a part of it. Wish you all the best for the quiz.
Thank you, ma'am.
Thank you. Thank you.
All geared up? Shall we begin now?
Thank you, ma'am.
Yes, ma'am.
Okay. Yes. So get set and go. We'll be picking
Yes, ma'am.
Right. We'll be picking up one slip to begin with the round 1 of set A. These are the slips.
Yes, ma'am.
These are the slips, and we'll be picking up one slip out of these. To be fair, okay. I picked up one slip. Let's see who it is. Can you all read the name?
No, ma'am, I can't see anything.
Okay.
Yeah. Me too.
Neetu, right. So Dr. Neetu,
Not able to see anything.
are the opening batsman or rather batswoman for today. So let's have it there. The first question of round 1 of set A will be addressed to you. Are you ready?
Yes, ma'am.
Right. Nobody else answers the question but Dr. Neetu. What type of pennation is seen in tibialis anterior muscle? 15 seconds.
Bipinnate.
That's the incorrect answer. In a patient, the triceps muscle, this is also for you, Dr. Neetu. In a patient, the triceps muscle is spared, but the brachioradialis and the wrist extensors are paralyzed. Okay, understood? The triceps is spared, but brachioradialis and wrist extensors are paralyzed. Name the nerve that is injured and mention the site of injury.
Radial nerve and the radial groove.
Okay, great. Full marks for that. Now, as per sequence, after Dr. Neetu, the serial order is Dr. Shaheen Rizvi. Dr. Shaheen, are you prepared?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
The next set of questions is for you. Which vein draining the cerebrum begins at the anterior perforated substance and how is it? Seconds, Dr. Shaheen.
The great cerebral vein.
Yes, sorry, that is an incorrect answer.
It is formed by.
No, the answer is incorrect, Dr. Shaheen. I'll have to stop you there. The second question addressed to you is, in an automobile accident, a rider sustained a severe neck injury. In addition to the crushing of the spinal cord, the transverse process of the cervical vertebrae was also fractured. Which artery was endangered?
The vertebral artery.
Okay, great. Full marks for that. Dr. Divya Vashne, are you there? Am I audible, Dr. Divya? Dr. Divya, please unmute. Are you there? Am I audible to you, Dr. Divya? Okay, I guess there's some issue. We'll take her in the last. Dr. Sangeeta Palani, are you there?
Yes, ma'am.
Okay, the next set of questions is for you. Name a front of thigh muscle which flexes both hip and knee joints, and also mention its nerve supply.
Sciatic nerve.
Front of thigh muscle. Okay, I'm so sorry. That's an incorrect answer.
Ma'am, I didn't answer that.
Okay. Dr. Who's that who's answered? But the time's up, Dr. Sangeeta. Would you still like to take that chance?
Is it sartorius?
Okay, what do I do now? Right at the margin. Okay, let's see how we'll put a question mark there and we'll keep it noted. The next question addressed to you is: a 40-year-old patient suffered acute dental pain. The attending dentist found caries affecting the mandible and molar. Which nerve does the dentist emphasize to work on that tooth? Did you get the question?
Yes, ma'am. Yes, ma'am. Inferior alveolar nerve.
Okay, great. Full marks for that answer.
Ma'am, the first one I didn't answer. I was about to answer sartorius, but someone else answered it.
No. We'll keep that into consideration. We'll see. If there's a tiebreaker somewhere, we'll consider it. It was just in the nick of the time, so I'll see what I can do now. But for the second question, you get full marks.
Yes.
The next in order, Dr. Divya, am I audible to you now? Can I come back to you? So we move ahead. Dr. Merrill, are you?
Hello. Hello. Ma'am, Dr. Merrill here. Hello.
Yeah, you're audible. Fine. The next set of questions is addressed to you, Dr. Merrill.
Yes, ma'am.
What is the direction and the degree of rotation of that loop during
The direction.
what is the direction and degree of rotation of the midgut loop?
The direction is towards the left side. Degree of rotation is 90 degree.
Okay, and give you marks for that. Sorry. The next question that comes to you is: a 58-year-old woman has difficulty in swallowing and frequently aspirates fluids while drinking. She's diagnosed with a skull-based tumor that is occupying the space behind the jugular foramen. Compression on what structure is most likely to cause her symptoms? Have you understood the question? There's a tumor right behind the jugular foramen, and she's having difficulty swallowing and aspirating fluid. The time starts now.
Okay. There's a compression. That means it is compressing the nerve. Hello. Hello. Am I audible? Compression of the nerves over there. Near the jugular foramen means 9, 10, 11 nerves are there.
Okay, fine. I'll give you marks. There were extra nerves, but I'll give you marks. 11th was not needed there, actually. Okay. So the next participant is Dr. Darshita. Am I audible to you, Dr. Darshita?
Yes, ma'am.
Okay. The next set of questions is addressed to you. The first question is: name the artery that supplies the sinoatrial node.
Ma'am, SA node is supplied by the right coronary artery.
Okay. Get marks for that. Good. This is the second question. During childbirth, an excessive anteroposterior compression of the head tore the attachment of falx cerebri from the tentorium cerebelli. This was followed by bleeding. What is the cause of bleeding and why?
Ma'am, it is the extradural bleed from the dural veins.
Could you name the structure that was torn at the attachment of falx cerebri and tentorium cerebelli?
At the attachment of falx cerebri with the tentorium cerebri. I can't get you what are you asking, ma'am.
There was a, even though the time's over, but because you were trying, I can explain it in a better manner. Falx cerebri is attached to tentorium cerebelli. There was a tearing at this point. What structure was the cause of bleeding at this point of junction of falx cerebri with tentorium cerebelli?
Is it cavernous sinus?
Sorry, that's an incorrect answer. Thank you. Only one of the question was answered correctly by you. We continue with the next participant. Dr. Nikhil, are you there?
Yes, ma'am.
Okay. So the next set of questions will be addressed to you. The first question is, name the muscle of the medial compartment of thigh which has a dual nerve supply.
Sartorius. Oh, sorry, medial compartment. Sorry, ma'am. Medial compartment. Sorry, ma'am. Ma'am, medial compartment. I just forgot medial compartment. Okay.
No, but that is what you were supposed to be noting. I'm sorry, I will not be able to give you marks for that. The second question, please be more careful this time. A 50-year-old female patient was diagnosed with a pituitary adenoma. A hypophysectomy was scheduled for her. The tumor can be approached transnasally through which sinus and why?
Sphenoidal air sinus.
Okay, good. Marks for you. Why? Why sphenoidal sinus is chosen to approach to the pituitary?
Just the pituitary fossa lies just over this sinus. So, ma'am.
Right. That is the correct answer. Full marks for that.
Thank you, ma'am.
Right. The next participant in sequence is Dr. Devasha. Are you there?
Yeah, ma'am.
Devasha, am I audible?
Yes, ma'am, audible.
Okay. So the next set of questions is for you. The Edinger-Westphal nucleus is a component of which nerve?
Ma'am, oculomotor.
Okay. Answered right in time. Second question, a patient presents with the chief complaint of bleeding from the nose. Where is the likely site of bleeding situated? And decides to ligate a branch of maxillary artery. Which artery could this be? There are two parts to that question. Your time starts now.
Ma'am, sphenopalatine artery.
Okay, that was one part answered correctly. I give you half the marks. But where is the likely site of bleeding in the nose? Okay, no marks for that. One part was answered correctly. You've been partially marked for the second question, and you've been given marks for the first question. Now the next participant is Dr. Bhavesh. Are you ready?
Yes, ma'am.
Okay, Dr. Bhavesh. Your questions are, which nerve pierces the psoas major muscle and emerges on its ventral surface?
Sciatic nerve.
Okay, that's an incorrect answer, Bhavesh. I'm sorry. The second question is, a 25-year-old college student was examined by the physician for sinusitis. A purulent discharge was seen in the superior meatus of the nose. The first part of my question is the discharge coming from maxillary sinus? Only answer yes or no. There is a discharge in the superior meatus. Is it from the maxillary sinus or no?
Yes, ma'am.
Yes, okay. That, the second part becomes irrelevant. Which paranasal sinus is likely to be infected? Both are very interrelated, you know.
Yes, ma'am.
Would you still like to answer the second part? If not maxillary, what is the sinus infected?
Likely to be affected.
Okay, time's up, Bhavesh. So sorry for that.
Ethmoidal, ma'am. Ethmoidal.
I can't give you marks for that. There was a delay in the answer. The time was up. You just need 50 seconds to answer. I'm so sorry. The next participant is Dr. Pankaj. Am I audible to you, Dr. Pankaj?
Yes, ma'am.
Okay. So here's your question. What is the nerve supply of pyramidalis muscle?
Gluteus maximus. Sorry. Sciatic nerve.
Sciatic nerve. Okay, that's an incorrect answer. A 60, this is your second question, and the time will start after I end my question. So, pay attention to what is being asked. A 60-year-old man underwent a left-sided hemiglossectomy with blocked dissection of lymph nodes of the posterior triangle of left side of neck. Which nerve was at risk to injury during the surgery? And name one muscle paralyzed because of injury to this nerve. That's a simple question. Your time starts now. Time's up, Dr. Pankaj. So sorry for that. Now we have Dr. Anbarasan. Are you there?
Yes, ma'am.
Okay. Did I pronounce your name correctly? That was a tough name for me to pronounce. Is
Yes,
it?
ma'am. Yes, Anbarasan. Yes, ma'am.
Okay, okay, Anbarasan. This is your first question. Inferior petrosal sinus drains the cavernous sinus into which vein? Just name the vein. Your time starts now.
Right cerebral vein.
Incorrect. The next question. Irritation of the diaphragm may cause a referred pain in the shoulder region. Name the nerve to the diaphragm. The first part. Name the nerve to the diaphragm. The motor nerve to the diaphragm. Rhenic. Good. Okay. The nerve to the diaphragm shares its spinal segments with another nerve. Name the nerve which is responsible for the pain in the shoulder region.
Spinal segment.
Accessory nerve. I'm sorry, that's an incorrect. So you were partially correct for your second question. We'll give you half the marks there. Now the last participant whom we were unable to connect is Dr. Divya Vashne. Am I audible to you, Dr. Divya? You are not audible to me. Please unmute.
Ma'am, am I audible now?
Yes. Now you're perfectly audible to me now. Are you prepared, Dr. Divya?
Okay, ma'am. Okay.
So
Yes, ma'am.
Here's your first question. Which nerve supplies the skin at the angle of mandible?
Ma'am, facial nerve. Sorry, ma'am. Sorry.
Sorry.
Mandibular nerve. Sorry, ma'am. Sorry, ma'am. Sorry.
Sorry, dear. I'm sorry.
Sorry, ma'am.
You answered it incorrect.
Mandibular nerve. Sorry.
We go to the next. A stab wound just above the left clavicle, lateral to the sternocleidomastoid muscle, may be life-threatening because of the possibility of injury to which structure or structures. A stab wound just above the left clavicle lateral to the sternocleidomastoid. Your time starts now.
Ma'am, brachycephalic artery, left, left common carotid.
Your answer is incorrect. I'm so sorry. I'll have to complete the round 1 and have to delay by a minute's time before I begin with the next round. So please stay connected.
Okay, ma'am. Okay, sure, ma'am.
So the first round of set A is over. I'll be switching off my video for a second's time. Please stay connected. Just a second, we are about to start the round 2. So, the round 2 of set A. We'll have to pick a name slip again. Dr. Kanchan, would you do me a favor and pick up one slip from this? Is the name visible to all? It is Dr. Sangeeta. Okay. All the participants have been muted by us, and only the participant to whom the questions are addressed will be unmuted. So, Dr. Sangeeta, please unmute yourself to answer the set of questions.
Yes, ma'am.
Okay. Identify the arrow marked structure.
Ma'am, it's answer cervicalis.
Okay, great. Full marks for that.
Thank you.
Right. Thank you so much. The next participant is Dr. Merrill.
Yes.
Dr. Merrill, please unmute yourself.
Hello.
Okay, yeah. Identify the arrow marked structure.
Ma'am, is the lateral pterygoid plate.
Okay, maybe the arrow is not clearly pointed, but I'll give you marks for that. Okay, full marks for that. The next participant is Dr. Darshita. Please be prepared. Unmute yourself, please. Right. Identify the arrow marked structure.
Ma'am, this is the petrous part of the temporal bone.
Okay. Could you be a little more specific, Dr. Darshita?
Ma'am, it is the anterior wall of the.
Okay, I'll still give you marks for that. Okay, fine. Could have been a little more specific. The next participant is Dr. Nikhil. Would you please unmute yourself, Dr. Nikhil?
Yes, ma'am.
Okay. Identify the arrow marked structure. Dr. Nikhil, sorry, the time's up. The next participant is Dr. Devasha. Please unmute yourself, Dr. Devasha.
Yes, ma'am.
Identify the arrow marked structure.
Ma'am, vein, cerebral vein.
Is the arrow in the cerebral vein? Is the arrow clearly visible to you?
Yes, ma'am. Ma'am, sinus.
Let me wait till the time's up. Okay, the time's up. Dr. Devasha, I can't give you marks for that. That's an incorrect answer.
Okay, ma'am.
Dr. Bhavesh, you are in sequence next. Please unmute yourself. Please unmute yourself, Dr. Bhavesh. I can't hear you. Am I okay? Right.
Yes, ma'am. Yes, ma'am. Okay, ma'am. Yes, ma'am.
This is your question, Dr. Bhavesh. Identify the arrow marked structure.
Ma'am, muscles and ma'am, anterior belly of omohyoid muscles.
No, I'm sorry, Dr. Bhavesh. That's an incorrect answer. That is not the anterior belly of omohyoid. I can't give you marks for that.
Strap.
Yes, you could be hinting at the correct answer. Both of them are part of that, but which one? Which one? Your first answer was incorrect, so unfortunately, I cannot give you marks for that. We move to the next participant, that is Dr. Pankaj. Please unmute yourself, Dr. Pankaj.
Yes, ma'am.
Okay. Identify the arrow marked structure. The arrow is pointing towards a muscle. What is that muscle?
Palatoglossus.
I'm sorry, that's an incorrect answer. We move to the next participant, Dr. Anbarasan. Please unmute yourself.
Yes, ma'am.
Identify the arrow marked structure.
Yes, yes, ma'am. This is ligamentum denticulatum.
Yes, great, great. Full marks for that. That is the right answer. I move to the next participant, Dr. Neetu. Please unmute yourself. Right.
Yes, ma'am.
This is your question. Identify the arrow marked structure. It is pointing towards a blue colored structure. Please identify that structure.
Inferior thyroid vein.
Great. That's the correct answer. Full marks for that. Dr. Shaheen, please unmute yourself. Dr. Shaheen Rizvi, am I audible to you? Please unmute yourself. Right.
Yes, ma'am.
Thank you. This is your question. Identify the arrow
Yes.
marked structure. The arrow is pointing towards a muscle. Look carefully and identify the structure.
Inferior belly of omohyoid.
Great, that's the correct answer. Thank you. Dr. Divya, please unmute yourself. This is your question. Identify the arrow marked structure, the yellow colored structure there.
She had quit.
Dr. Divya? Dr. Divya Vashne?
She's joining on the.
Dr. Divya, can you hear me? Am I audible to you, Dr. Divya?
Yes, she's joining.
So, ma'am, am I audible?
Yes, yes. You're very much audible, Dr. Divya. This is your question. Please identify the arrow marked structure. That's the yellow colored structure where the arrowhead is pointing. Please identify that structure. Time's up, Dr. Divya. I'm sorry. Can't give you any marks on that question. That completes the second round of set A. Now we will proceed with the third round of set A for all the 11 participants. We will have to pick up a name slip again to select where the round begins from. I will ask Dr. Kanchan to select a slip for me. Okay. Can everybody see the name? Okay, so Dr. Bhavesh, please unmute yourself.
Yes, ma'am.
Okay. So the first question of round 3 is addressed to you. Highly skilled voluntary movements of the body are controlled by which deep nucleus of the cerebellum? Your time starts now.
Voluntary movement. Alright. Cerebral nucleus.
Try, Dr. Bhavesh, but I'm sorry, no marks for that. Time's up. I'll have to move to the
Ventral posterior.
Dr. Bhavesh, I'll have to move to the next participant. That was an incorrect try. I move to Dr. Pankaj. Please unmute yourself.
Yes, ma'am.
Okay. This is your question. Name the site from where the cerebellum develops. Time's up, Dr. Pankaj. I'll have to move to the next participant. Dr. Anbarasan, please unmute yourself. Am I audible to you, Dr. Anbarasan?
Yes, ma'am. Audible, ma'am.
Okay, this is your question.
Yes, ma'am.
Which lymphatic organ exhibits the presence of both an afferent and an efferent lymph vessel?
Lymph node.
Okay. Okay, fine. We move to the next participant.
Mr. Sultan.
Right, right. We move to the next participant, that is Dr. Neetu. Please unmute yourself.
Yes, ma'am.
Okay. This is your question. The blood testis barrier in the testis is formed by which cell? Your time starts now.
Sertoli cell.
Okay, good. Right. Full marks for that.
Thank you.
Okay. We move to Dr. Shaheen Rizvi for the next question. Dr. Shaheen, please unmute yourself.
Yes, ma'am.
Nucleus ambiguous belongs to which functional column in the brainstem? Your time started. Nucleus
General visceral efferent.
Okay, great. Correct answer. Full marks for that. We move. That was Dr. Sangeeta. That was Dr. Shaheen. So we move to Dr. Divya now. Dr. Divya.
Shaheen.
That was Dr. Shaheen. We move to Dr. Divya now. Dr. Divya, please unmute yourself.
Yes, ma'am.
Okay. This is your question. The place where the periphery of one osteon comes in contact with another osteon is known as?
Interstitial lamella.
Can't give you marks.
Interstitial lamella.
Can't give you marks for that. Sorry, that's an incorrect answer. We move to the next participant. That's Dr. Sangeeta. Please unmute yourself. Okay, Dr. Sangeeta, this is your question.
Yes, ma'am.
What are Hassel's corpuscles formed from?
Corpuscles. And secretory deposits.
Can't give you marks for that, Dr. Sangeeta. Sorry, that was an incorrect response. We move to Dr. Merrill now. Dr. Merrill, unmute yourself, please.
Hello.
Yeah. Your question is, what is the location of the tract of Lissor? Just tell me the location, nothing else.
It is actually a connection for the dorsal column pathway, the ascending and the
Sorry, Dr. Merrill, I wanted the location. Where exactly was it located? In reference to the horns and the circle of the spinal cord, but you were not able to answer it correctly, so no marks for that. Sorry. The next question is for Dr. Darshita Singh.
Yes, ma'am.
Okay. What type of impulses do the posterior external arcuate fibers convey?
They carry sensory impulses.
What sensation?
Means they undergo sensory decussation for the.
Repeat your answer.
Yeah, sensory.
I wanted the type of sensation carried by these fibers.
Okay.
You still want to answer?
Fine touch and...
No, I'm sorry. That's an incorrect response. I move to the next participant. Dr. Nikhil, are you there?
Yes, ma'am.
Okay. Which region of the stomach shows the presence of deep gastric pits?
Ma'am, pylorus.
Okay, great. That is the correct answer. Full marks.
Thank you.
The next question is for Dr. Divasha. Please unmute yourself.
Yes, ma'am.
Okay. The smooth muscle cells of tunica media of the afferent glomerular arterioles are modified to form which structure in the kidney?
Ma'am, juxtaglomerulus apparatus.
Okay, good. That is the answer. Good. Full marks for that. That ends the set A of our quiz. Give me 2 minutes to total the scores and I'll let you all know who are the lucky 6 participants that move to the second set. Give us just 2 minutes to total the score. So we are back with the scores. Not a very pleasant thing that I love doing, but I'll have to let you know who are the lucky 6 participants that move with us to the set C. They are Dr. Neetu Sivadasan. Am I audible to you all? Okay. Dr. Neetu Sivadasan, Dr. Shaheen Rizvi, Dr. Anbarasan, Dr. Divasha, Dr. Sangeeta Palani, and Dr. Meryl Rachel John. These are the 6 lucky participants that move to the second set of questions, the set B. The rest of you can please switch off your video mode, but please stay connected while the quiz is on. We'd love to have you during this journey. Please don't leave the quiz. Be there with us. Okay, so the lucky 6 participants now will move on further with the second set of questions meant for you. Shall I move on? Give me a thumbs up. Am I audible? Okay. Let me pick up a name slip. नाम हटाओ ना बच्चे. So this is the slip. We begin with you, Dr. Merrill. Please unmute yourself.
Hello, ma'am.
Yeah, that's okay. So the first question of round 1 of set B is addressed to you. Where can the primordial germ cells be located at the 3rd week of embryological development? Your time starts now. 3rd week of development, primordial germ cells.
3rd week of development means it will be a stage of bilamellar disc, close to the yolk sac.
Okay, great. That's the correct answer. Full marks. Okay. Great. We move on to the next participant. Just strike off the names of the participants who are not there. Strike off and give me, I need to ask. Dr. Devasha. Please unmute yourself.
Yes, ma'am. Yes, ma'am.
The next question is for you. What is the name of the critical event during meiosis that helps to redistribute the genetic material? Just name it.
Ma'am, pectin.
Could you please repeat yourself?
Ma'am, crossing over pectin.
Crossing over. Fine. That's the correct answer. Full marks for that. We have Dr. Anbarasan to face the next question. Please unmute yourself. Okay. This question is for you, Dr. Anbarasan. Please unmute.
Yes, ma'am.
Okay. Name the master gene responsible for the development of testes in a developing embryo.
SRY gene, ma'am.
Okay, great. Correct answer. Full marks for that. That is Dr. Anbarasan. Now the next question is addressed to Dr. Neetu Sivadasan. Please unmute yourself. Okay. At birth, the spinal cord extends up to which vertebral level?
Upper border of L3 vertebra.
Okay, correct answer. Full marks for that, Dr. Neetu. We proceed with the next participant, that is Dr. Shaheen. Please unmute yourself, Dr. Shaheen.
Yes, ma'am.
Okay. The cranial end of the neuropore usually closes by which day of development?
The 25th day.
Great, full marks for that answer. Good. Now the last participant for this round, that is Dr. Sangeeta Palani. Please unmute yourself.
Yes, ma'am.
Okay. What is the embryological remnant of the paramesonephric duct in males?
Appendix, ma'am.
Complete. Appendix what?
The testis epididymis appendix.
Okay, great. Full marks for that. So congratulations.
Appendix of the epididymis.
Right. Full marks for that answer. So with that, we end the round 1 of set B and we proceed to the second round of set B. For this, we'll again have to pick and choose one participant. we begin this round with is that visible to all? Dr. Neetu, please unmute yourself. Identify the arrow marked structure.
Medial pterygoid.
Great, correct answer, full marks.
Ma'am.
That is right, that is right.
Thank you, ma'am. But if it is all right, can I just say something? Actually, the previous answer, appendix of epididymis is actually a remnant of mesonephric duct and not paramesonephric.
What did she answer? I
Appendix of epididymis.
Ask my scorekeeper what answer was given. I'll just check it.
Yes, ma'am.
I'll just see what the answer was given from my scorekeeper.
Yes, sure, ma'am. Thank you.
Thanks for that concern that you showed there. Thank you so much for that and being so attentive. So you get full marks for your answer. We proceed with the next question, which is addressed to Dr. Shaheen Rizvi. Please unmute yourself.
Yes, ma'am.
Okay. So this is your question. Identify the arrow marked structure.
That's the palatoglossal fold.
Palatoglossal fold. I'm sorry, Dr. Shaheen, that's an incorrect answer. We move to the next participant. Dr. Sangeeta Palani, please identify the arrow marked structure. The time begins now.
Levator labii superioris alecmasi.
I'm sorry, that's an incorrect answer. That's the risorius muscle. Okay, we move to the next question. That is for Dr. Merrill Rachel John. Please unmute yourself, Dr. Merrill. Am I audible, Dr. Merrill?
Hello?
Yes, Dr. Merrill. You're audible to me, right? That's your question now. Identify the arrow marked structure.
Ma'am, it's the medial pterygoid muscle.
That's an incorrect answer, Dr. Merrill. That's not
the masseter.
Did you say something else? I heard you said medial pterygoid, but that's an incorrect answer.
Yes.
Okay, so no marks for that. Now we proceed to Dr. Devasha. Dr. Devasha, are you there?
Yes, ma'am, I'm here.
Okay. So this is your question now. Identify the arrow marked structure.
Ma'am, inferior alveolar artery.
I'm sorry, Dr. Devasha, that's an incorrect answer. That's the facial artery. No marks for that. Move to the next participant, that is Dr. Anbarasan. Are you there, Dr. Anbarasan? Okay.
Yes, ma'am, not audible.
Right. This is your question. Identify the arrow marked structure.
That external jugular vein.
Could you please repeat yourself?
That is retromandibular vein.
No. Now this is the answer, but I heard you say something else first.
First, that is red.
So I cannot give you marks.
Yes.
I guess you said external jugular vein first.
Yes. Retromandibular. After that, I seen the arrow mark.
Now I can't give you, you only get one chance to answer it correctly. I cannot accept the second answer that you give in succession. And from now on, please, all of you be a little careful. Only the first answer that you give will be taken as your answer, correct or incorrect. I will not accept second answers. Probably I was a little inattentive in one of the previous answers pointed out to me by Dr. Neetu. So I'm being a little more vigilant now and I'm checking you again. So that was the incorrect answer. You get no marks for that. Now we proceed to the next set of rounds. And for that, we have a new person to begin with. Okay. Again, it's Dr. Neetu this time. Dr. Neetu, we begin with you. The first question of round 3 of set B. Observe the image, identify and name the process. Just the name. I do not want any details. Your time starts now.
Yes. TTTS, twin to twin transfusion syndrome.
Okay, yes, this could happen because of twin to twin transfusion. I'll give you marks for that. This is fetus papyricius. That is one of the complications that can happen in twin to twin transfusion. I take that answer as correct. Good. Full marks for that. Now the next is Dr. Shaheen Rizvi. Please unmute yourself.
Yes, ma'am.
Okay, I think we'll give the second question to Dr. Neetu again before proceeding to Dr. Shaheen. Dr. Neetu, please unmute yourself. The second question is also addressed to you. Please unmute yourself. Okay. So this is your question. Identify and name the anomaly.
This is holoprosencephaly with what is it called?
Unfortunately, Dr. Neetu, I wasn't looking for that. I was looking for the answer synophthalmia. Okay. So, there's both the eyes are fused in the image. There's no midline structure. This is a clear image of what a synophthalmia looks like. So I proceed with the next participant. That's Dr. Shaheen. So sorry, Dr. Neetu. Participant 2, Dr. Shaheen, are you prepared?
Yes, ma'am.
Okay. Observe the 2 consecutive images. Identify and name the process. Image 1 is preceded by image 2. What is the process that is happening to the cells that you can see? Your time starts now.
That is cleavage formation.
Is that your answer? In case that was your answer, that's the incorrect answer. Cleavage is of course taking place, but what I was looking for is the process, and the process that you can see here is compaction. Okay. So you do not get any marks for your answer there. Now this is a second question for you, Dr. Shaheen. Please stay connected. Are you there?
Yes, ma'am.
This is your second question. Name and identify the anomaly.
That is gastroschisis.
I'm sorry, Dr. Shaheen, that is an incorrect answer. That is serenomylia.
Omphalosis.
No, there's no omphalosis, exactly what I was looking for. You could have focused on the lower limbs, the lower part of the trunk and the lower limbs.
Oh.
Okay, so that's an incorrect answer. Sorry, no marks for that. We move on to Dr. Sangeeta Phalani. Dr. Sangeeta, please unmute yourself.
Yes, ma'am.
Okay. So your first question comes now. Observe the image, identify and name the process that you can see taking place.
Ma'am, that's primitive node and primitive streak
Good, great.
and new relation process.
Correct answer. Full marks for that. That is the formation of primitive streak and primitive node. Okay. The second question that comes your way, identify and name the anomaly.
Coloboma iridis.
No, I'm sorry. It is a complete aniridia. There is no coloboma. There is no iris actually. So it's an image from a baby who has aniridia. Okay. Sorry, no marks for that. We move on to Dr. Merrill. Dr. Merrill, please unmute yourself.
Hello.
Okay, actually, I think that was, we've completed that round.
Hello. Ma'am, I didn't get a question.
Okay, okay. In that case, we'll take up these embryology questions later on. We'll continue somewhere. Dr. Merrill, we'll take you to the next question.
Hello.
Hello.
Okay. Hello. Yes.
Hello. Who's that?
Hello, Dr. Merrill. Hello. Ma'am, I didn't get the question.
Yeah, Dr. Merrill, we'll come back to you later for the question. We are calculating our scores till now and we'll come back to you a little later. Just give me a minute's time. Is the screen visible to all? Is it? Okay. Shall we continue further? The question was addressed to Dr. Merrill. Dr. Merrill, please unmute yourself. Dr. Merrill, are you there?
Hello?
Okay, yes. Dr. Merrill, this is your question. Please identify the given slide. I'm sorry, the time's up. Dr. Merrill, no marks for that. We proceed to the next. Dr. Devasha, please identify the slide. Dr. Devasha, please unmute yourself.
Yes, ma'am.
Okay, please identify the slide. Dr. Devasha, time's up. I'm sorry, no marks for that.
Yes, ma'am.
We move to Dr. Anbarasan. Dr. Anbarasan, please unmute yourself.
Yes, ma'am.
Okay, here's your question. Please identify the given slide.
Yes. Time is, ma'am.
Okay, marks for that.
Thank you.
That is the
Second.
correct answer. Thank you. That completes.
Second question, ma'am. Second question.
For histology, there was only one question for each participant.
Thank you.
Okay, that completes the set B of our quiz. We'll be totaling the scores and we'll be letting you know who are the 3 lucky finalists that move to the set C. Just give us a minute's time. We are back with the final scores for the set C. Am I audible to all the participants? Okay, you can raise your hands to let me know. Am I audible to you? Okay, fine. Thank you, Dr. Neetu. So we have 3 finalists who are going to go up to the set C of our questioning. The lucky 3 are Dr. Neetu, Dr. Shaheen, and Dr. Anbarasan. Dr. Sangeeta and Dr. Shaheen had a tie. So we had to average your marks depending upon what you scored today and what you scored in the preliminary rounds. On the basis of averaging, Dr. Shaheen scored a little more as compared to Dr. Sangeeta. So the three finalists are Dr. Neetu, Dr. Sangeeta, and Dr. Anbarasan. The rest of you may please switch off your video modes, but do stay connected with us. Thank you so much. Well, all the three participants, are you ready? Dr. Neetu, Dr. Sangeeta, and Dr. Anbarasan. Are you ready? No, Dr. Shaheen, Dr. Anbarasan, and Dr. Neetu. Are you ready? Okay. So we begin with set C, round 1. Dr. Kanchan, please do me a favor. Thank you. Well, what do I call this? It's again Dr. Neetu this time, who begins with this round. So Dr. Neetu, unmute yourself, please. Okay. So the first question of the first round of set C is for you. Identify the slide and the arrow marked structure.
It's pulmonary artery.
And there were two parts. One part is the slide and the other part is the arrow marked structure.
It's the lungs and pulmonary artery.
Okay, the first is correct, the second is incorrect. Give you half the marks for that. You get 5 marks for answering it partially. We move on to the next participant. That is Dr. Dr. Shaheen. Dr. Shaheen, please unmute yourself.
Yes, ma'am.
Okay. Please identify the slide and the arrow marked structure. There are two parts, the slide identification and the arrow marked structure, and your time starts now.
This is the slide is of the tongue.
Okay. Well, you could only manage to answer it partially within the time span. So I give you half marks for that. The slide is that of tongue, but you could not answer the second part. So no marks for that. I move on to the third participant, Dr. Anbarasan. Please unmute yourself.
Yes, ma'am.
Okay. This is your question. Identify the slide and the arrow marked structure.
Prostate.
Okay. The arrow marked structure?
Prostatic gland.
Okay, you get only half marks for that. Half of it answered correctly. So all my participants could only manage half of it in this round. All of you get 5 marks each for the questions that were put forward to you. So we move on to the second round of the set C. Now, because we began from Dr. Neetu and we just have 3 participants, I'm beginning the second round with Dr. Shaheen. Fair enough? Or you want me to pick up the slip? Let me know. Is it fair with all my participants? All of you, is it fair or should I pick up? Okay, a thumbs up from all.
Okay.
Dr. Shaheen, is it okay?
Yes, ma'am.
Okay, okay. So we begin the second round with
Yes,
you.
yes, ma'am.
Okay. So I begin the second round of set C with you, Dr. Shaheen. That's your question.
Yes, ma'am.
What is the stage of oogenesis in a female child at the time of birth?
Primordial follicle.
Okay, I can give you marks for that.
Meiosis.
Right. I'm giving you marks for that. What stage? Could you be more specific?
That is meiosis.
Meiosis arrested in which stage at the time of birth? Okay, I've given you marks for that. In any case, you don't need to answer it further. That's okay. I move on to the next participant, Dr. Anvarasan. Are you there? Please unmute yourself.
Yes, ma'am.
Okay. This is your question. The superior vesical arteries are derived from which embryological artery?
Umbilical artery.
Okay. Could you be a little louder? I could hear you clearly.
Umbilical artery.
Okay, great. Full marks for that, Dr. Anvarasan. Good. We proceed to our third participant for her question. That is Dr. Neetu. Please unmute yourself. The ductus arteriosus is derived from which aortic arch?
Sixth aortic arch. Left sixth aortic arch.
Right. Full marks for that, Dr. Neetu. That ends this round and we proceed further. Shall I ask my scorekeeper? Is that okay, Dr. Kanchan? Okay, fine. We proceed further from here. And we move to the rapid fire round. So some instructions before proceeding further. The rapid fire round will have 8 questions, EIGHT, 8 questions addressed to each of the participant. You score 10 marks for answering it correct, but there will be a deduction of 5 marks, -5 for an incorrect answer, +10 for a correct answer, -5 for an incorrect answer. You get only 5 seconds to answer each question, not 15. Okay, we are on rapid fire, so you get only 5 seconds time to answer each question. A correct answer will get you 10 marks, an incorrect answer takes away 5 marks. And there are 8 questions for every participant. Am I very clear on that? Okay. The first answer will be taken as your final answer. You will not be given a second chance and a second guess. Okay. So we begin with Dr. Anvarasan. Dr. Anvarasan?
Yes, ma'am.
Unmute yourself.
Yes,
Okay. That's the rapid fire. Do you want me to pick up a slip or shall I begin it with Dr. Anvarasan? I'm giving everybody a fair chance to begin with.
Yes, no problem.
Okay. Okay, Dr. Anvarasan. So here comes your question. Name a site where the cardiac muscle can be found except the heart. Okay, no marks. You can leave a question like he did. If you do not answer, there's 0. If you answer correct, there's 10. If incorrect, -5. So of course, you can pass the question, but please be clear. If you do not want to answer, say pass, and I'll move to the next question.
Yes, ma'am.
Okay. So the second question. Which tract originates from the neurons of the Clarke's column? No answer there. The third question. Which medullary vellum is continuous with the cerebellar white matter?
Superior.
That was at the nick of the time. Let's see. There's a question mark there. I may not be able to give you marks, but I'm keeping it on the side. Okay. The next question, please be very particular about the time. You answered right on the bell, so I'm giving you marks. Do not repeat it again. Please be a little quicker. The muscles can be excited by a blood-borne hormone. Is that true or false? Muscles can be excited by blood-borne hormone.
True.
What did you say?
True, ma'am.
Okay,
True.
good. That's the right answer. True. Maternal component of placenta is from decidua parietalis. True or false?
False, ma'am.
False. That's right. The vitelline veins form the cable system of veins in the adults. Is that true or false?
True, ma'am.
That's an incorrect answer. That's an incorrect answer. The next question. The collagen in endomysium, perimysium, and epimysium is different in structure. Is that true or false?
False, ma'am.
Incorrect. It is true. They are all different structurally. The collagen content is different. So that was an incorrect answer. The last question for you, Dr. Anbarasan, is surfactant is produced by type 2 epitheliocytes. True or false?
True, ma'am.
That is the right answer. Okay. So with that, we end with the rapid fire round for Dr. Anbarasan, and we move to Dr. Neetu for the second set. Dr. Neetu, please unmute yourself. Okay. Are you prepared?
Yes, ma'am.
Okay. So here comes your set of questions. Name the characteristic granule found in the epidermal Langerhans cells. Time's up. We move to the next question. What is common between area postrema, the pineal gland, and the neurohypophysis?
They lack blood-brain barrier.
Wonderful. That's the right answer. We move to the third question. Which part of internal carotid artery gives branches to the trigeminal ganglion? Time's up. That is the cavernous part. Okay. So chronic sun exposure leads to increase in melanocytes and Langerhans cells in the skin. Is that statement true or false?
False.
False. That's the right answer. Okay. The allantois joins the posterior region of the cloaca. True or false?
False.
That's the right answer. WNT4 is the ovarian determining gene. Is that true or false? No answer there. Time's up. But that statement is a true statement. Okay. So we move on to the last participant for today.
Ma'am, 2 more questions.
Okay. So sorry. So sorry. That is 6. I'm so sorry. Yes. Your 7th question is, the palatine tonsils are derived from the first pharyngeal pouch. Is that true or false?
False.
Okay, that's the right answer. An absolute closure of foramen ovale occurs at birth. True or false?
False.
False. That's the right answer. Okay. That is the end of your rapid fire round. Pretty good score, Dr. Neetu.
Thank you, ma'am.
Great going. So we come to the last participant for the quiz today. Are you ready?
Yes, ma'am.
Okay. This is your first question, Dr. Shaheen. Which is the largest branch of the vertebral artery?
Subclavian artery.
Incorrect. Name the cells responsible for the regeneration of skeletal muscle. No answer there. What is the functional equivalent of the dorsal spinocerebellar tract in the upper limb? No answer there. Time's up for that question. Your 4th question Dr. Shaheen, the fetal breathing movements
Yes, ma'am.
before birth, is that true or false?
True.
Okay, that's the right answer. All of the pancreas except the lower part of the head is derived from the ventral pancreatic bud. Is that true or false?
False.
Oh no, but you answered late. Can't give you any marks on that. You answered correctly, but the answer was delayed. No marks for that. The last question.
I answered right at the bell, madam.
Okay, we'll see.
It's okay.
That's okay. The sixth question, the odontoblasts are the precursors for the formation of enamel. Is that true or false?
True.
Could you please repeat yourself? What did you say?
It's true.
No, but that's the incorrect answer. Okay, -5 for that. Okay. The height of an individual shows a diurnal variation. Is this statement true or false? No answer. We're taller in the morning when we get up. That's a true statement, okay?
Okay. Okay.
Okay. The corticospinal tract courses through the posterior limb of the internal capsule. True or false? No answer there. 0 marks for that. That
false.
That was true. That was true. But thankfully, you did not answer it in time. Otherwise, it would have been a -5. So 0 here. That ends the rapid fire for you, Dr. Shaheen. Let's have the total scores. Just give me a minute's time. Just give me a minute's time. No. Yes. So the final result is ready. We know who the first, second, and third are, but let that be a surprise for all of you. The final result of the quiz, I can only tell you one result. One of you is first, the other second, and the last one is third. That's the best that I can do. But the final result of the quiz will be announced during the valedictory function. So thank you all for that wonderful participation. It was amazing to be here with all of you. With that, I end the session for today. Kindly join us for the workshop tomorrow. Have a nice day to all our participants and to the wonderful audience who stayed with us till this late. Thank you so much and namaskar to all of you.